case. Over to you.
So I've got selected exercises of a CT head of a 17-year-old 17-year-old patient. There is a well-defined high attenuating lesion in the suprasellar region. Along with that, there is also isodense lesion that is on the along the left side of the frontoparietal region, and along with that, there's a right-sided optic nerve. There is a calcification thickening of the right optic nerve. And there is another lesion which is at the left cerebellopontine angle. So in this patient, there's actually a constellation of findings. I can see a mass in the cerebellopontine angle, and there is a lesion on the left side. So I'm thinking because of its location, it's a meningioma that is in the left frontoparietal region, and the lesion which is at the left cerebellopontine angle, because it is going into the porous acousticus, it makes me think that this could be a schwannoma. And however, I can see there's slightly isodense lesion on the right cerebellopontine angle as well, but I'm not sure that whether it's going into the porous acousticus or not. And based on these two findings, this patient's got meningioma and cerebellopontine angle masses. This could be NF2. I would like to see the spine as well if the patient has got any ependymomas there.
So what has been picked up is that there are multiple, can I request all of you to stop your videos? So now what we can see is that there is a meningioma here. There is another meningioma which is in the suprasellar region, and actually it extends along the optic nerve, and it is partially calcified, as we can see here on this bone window. And other than that, we can see some enhancement here, some enhancement here. We are worried about acoustic schwannomas. So in conclusion, what will be your suspicion till now?
It will be NF2.
NF2. What will you like to do now?
I would like to look at the spine to see that if the patient has got any ependymomas.
Right. So I'll show you the MR shortly. But first of all, let's revise the concept of NF2. Now, the definition of NF2 is bilateral acoustic schwannomas. If a patient has got bilateral acoustic schwannomas, the definition is met and we just call it NF2. Or there can be first degree relative with NF2 and either a unilateral acoustic schwannoma or any two of the following. What are the any two? They can be schwannomas, they can be neurofibromas, they can be meningiomas, they can be gliomas, particularly, ependymomas. And there's a typo here. There can be, posterior lens opacity, juvenile posterior lens opacity, which is missing here. So, way to remember it is this MISME, multiple inherited schwannomas, meningiomas, ependymomas. Point to remember here is that, please remember that neurofibromas can never happen within the intracranial cavity. Neurofibromas can, in and around the skull, for example, neurofibromas can be seen in orbit, they can be seen in the scalp, etc., but not within the intracranial cavity. On the other hand, schwannomas of the cranial nerves, they can happen within the intracranial cavity. So, other than 8th nerve, there can be schwannomas arising from other nerves, intracranial nerves also. This is one point to remember. Second point to remember is that whenever you see a case of NF1 or NF2, what will you do next? And of course, you have to check the whole of the neural axis, particularly the spine, and in that regard, ask for an MR. And this MR has to be with contrast. So this is your MR. Over to you, candidate one.
So as seen on the CT head, the MR, I've got the MR brain as well as the spine. There are bilateral cerebellopontine lesions which are of high signal intensity on the flare, and there are suprasellar and the left-sided meningiomas as well. However, when looking at the spine, in the cervical spinal region, there is intramedullary lesions which have got high signal on T2, and they are in keeping with ependymoma. So all the constellation of these findings are in keeping with NF2.
Right. What is this thing here? You see this? This is pons.
Yeah.
This is the midbrain. Anterior to the midbrain, something is enhancing here. So what is it? Which you can see it here also.
Is that the meningioma that is enhancing?
So this is a nodular type of enhancement.
Can't see exactly. That is anterior to the midbrain you're asking.
So what can it be?
I'm not sure. So normally the posterior pituitary is enhanced.
Any nerves which pass through this area?
It's a third cranial nerve that passes through that area, and the seventh as well.
Okay, so this is the level of the midbrain. And please remember, two nerves pass at this level. One is anteriorly, comes out of the midbrain anteriorly, which is the third nerve. And the second one is the fourth nerve, which comes out posteriorly and then passes through the ambient cistern and ultimately goes anteriorly. So it can be a schwannoma of either the third or the fourth nerve. This is the level of the midbrain. So other than that, just a recap what we see, acoustic schwannoma here, ice cream cone sign bilateral. You can see larger on left side, smaller on here. You can see the meningioma. You can see the suprasellar meningioma, which goes into the pituitary fossa also. Encases the internal carotid artery here and goes around the right-sided optic nerve. Then there is a schwannoma of third or the fourth nerve, as we have discussed. There is long segment tumor here, spining of the upper cord with some cystic component, and this is in keeping with an ependymoma. Another point to remember here is that an examiner can show this sequence to you in the beginning, and this sequence you have to develop your eyes to look at the optic nerve. Look at the optic nerve here and look at the optic nerve here, and there is a difference there. Once you pick it up, then you ask for further sequences. Yes, candidate one, over to you.
So on the selected MR images, the left-sided optic nerve has got a tramp track enhancement, and I can see that on the coronal images as well. And this is going into the superior orbital fissure as well, and I can see it up to the suprasellar region, and no other abnormality is seen. So I'm thinking that because it's a tram track appearance, this is what we see in the meningioma.
Right, very good. So if you see here, this is a fat saturated T1 weighted sequence post contrast. So please remember, in head and neck, in brain, you might not do fat saturation, but in head and neck, for example, you are scanning the orbit or the neck or the base of skull, you must do fat saturation. And you can see that there is tram track sign enhancement, and this enhancement actually through the optic foramen, it goes here close to the cavernous sinus. So again, point to remember is that an examiner can actually open a coronal sequence here, and you can see that there is enhancement here of the optic nerve sheath. Again, I warn you that coronal sequences can be the started sequence. Now, meningiomas can be, we are talking about the meningiomas of the optic nerve. They can have various kinds of shapes. So tram track sign is one shape, but it can be more fusiform, it can be globular. So just to highlight that it can have various kinds of shapes. Yes, please, your case once again.
So these are selected axial, coronal, and sagittal slices of a 37-year-old with seizures. And on these non-contrast CT hit, there is an area of low attenuation which is in the left frontal region, which has got surrounding area of relatively high attenuation. And I can see that there is some cortical hyperostosis as well at that region on the axial and the coronal bony recons. There is no midline shift. There is no ventricular effacement, and so there is no calcification within. There is another lesion which I can see, which is slightly hyperdense, and it is in the posterior part of the left parafalcine region. So I'm thinking that these, and there's one again in the anterior part of the left parafalcine region. So I'm thinking that these are multiple meningiomas. I would like to give contrast and see that whether they enhance with that or not, because I did not see any surrounding vasogenic edema, marked vasogenic edema. So I'm thinking that this could be meningiomas.
You want to give contrast? Instead, I have actually given you an MR with contrast. Over to you.
Okay, so on MR imaging, the lesions which we had seen on CT, they on so first of all, they appear to be hyper intense on the T2 weighted imaging, and they have got a signal of high intensity on T2 at the periphery. That is the large lesion on the left frontal region, and so there's only one lesion which has got a cystic change within it, and rest of them, they haven't. All these lesions, they have got a dural base tail, and they appear to be extra axial, and they are causing some mass effect anteriorly. And so I'm more in favor of these being meningiomas because they are multiple, and so one of them has got a cystic change within it as well.
Right. Now, I am showing you coronal post-contrast sequences. Do you pick up any other tumor? It's a bit harsh for me to ask you to pick up small tumors, some other tumors. Can you pick up something?
So I can see that there is asymmetry between the right and the left cerebral hemisphere, and the left temporal region has got hypoattenuation, low signal as compared to the right. So I'm thinking that there appears to be some loss of sulci and gyri at that region as well. So I'm thinking that there might be something at that region in the left temporal region.
Right. Do you see something enhancing here?
Yes, there is a small area of enhancement.
And do you see something enhancing here?
Yeah, there is enhancement there as well. Yeah.
So the sequence is slightly asymmetrical. So the right and left side is not seen on the same slice. But anatomy-wise, this is whatever you see here enhancing is enhancing here. So what do you think this is?
So these can be vestibular schwannomas.
Okay. Okay, very good, very good. We'll come back to your case. Now, just to, I think it is too harsh for me to just show you that post-contrast sequence with normal field of view and expect you to pick up the acoustic schwannoma. But what will happen in the exam? The examiner is going to show you a cis sequence, and this is a cis sequence. And on a cis sequence, you have to compare right and left side. And on this one, you can see that there is a bit of a black area here, a filling defect. So this is the vestibule, and there is a filling defect here. Once you pick it up, you raise the issue that I'm worried about acoustic schwannoma. I will like to confirm it with contrast. With contrast, you can see that it is enhancing here. And again, on an axial slice, it is enhancing here. Just a bit lower than the lesion itself, you can see the IAM here on the left side, IAM here. This is the cochlea, this is the cochlea, this is the vestibule, this is the vestibule. And here it is enhancing. So I do not have a cis sequence for this lesion, but having said that, consider that this is bilateral acoustic schwannoma. What will you do next? So the patient has bilateral acoustic schwannoma, so I'd be thinking about NF2. So patient should have neural axis imaging to look for ependymomas. Here you are. So again, in the spine, the sagittal and the coronal and axial slices, there are multiple lesions which are high on T2, along with some enlargement of the pod. They are intramedullary and they're in keeping with ependymomas. And yeah, but there is one lesion that is actually coming out of the neural foramina, which I can see on the axial slices. And this appears to be a schwannoma, which is coming out of the neural foramina. So the patient has got ependymomas and a schwannoma as well. Right. So this patient has got, we can see that multiple, lesions, what we call intramedullary lesion. And then we have got this enhancing lesion. It can be a schwannoma, it can be a neurofibroma. So another case of NF2. 46 years old, proptosis right. Over to you. So in these bony recons, the abnormality which I could pick is hyperostosis. That is in the right orbital region, and it is along the lateral wall of the right orbital region, and along with some thickening as well along the wing of sphenoid. And so I'm thinking that there isn't any other bony abnormality elsewhere. So I'm thinking that this bony hyperostosis would be because of any extra-axial lesion. So this extra-axial lesion can be a meningioma, because it should be an indolent lesion which has caused the bony hyperostosis, and it is quite asymmetrical. So what would you like to do?
I would do contrast enhanced CT to see.
Okay, so this is an axial CT on bone window. Can you describe the anatomy to me? What's happening here?
So on the right side, I can see that there is quite irregularity along the lateral margin of the right orbit, and it is extending up to the sphenoid, ipsilateral sphenoid as well. And I cannot see any other abnormality elsewhere in the bony calvarium. So that's the only abnormality which I can see.
Right. So now I'm showing you an MR, and because of time factor, if I can describe the sequences for all of you: P2, flare, P1. This is post-contrast fat saturated, post-contrast fat saturated P1, post-contrast fat saturated P1, and this is the CT. Can you please compare this with this, and describe what is happening?
Mm-hmm. So when we're comparing with the CT, we can see that there is, where there was area of bony hyperostosis, there is surrounding areas of enhancement around that lesion, which is tracking from the orbit, going around the bone, and it all appears extra axial to me. So there is enhancement in that area, and this enhancement, this could be tracking along the meninges, I think. And
so what is your conclusion?
So I think that this can be, I haven't seen such a meningioma before, but it is enhancing. It is along the bone. It is extra-axial. There is some dural tail as well. So this can be a meningioma, I think.
And what has happened then? It is going, this is the bone. It is on one side of the bone, and this is on the other side of the bone also.
So it has invaded the bone. So it is aggressive because the bone margins are quite fuzzy. So I think that this is aggressive lesion.
Right. Now, the point is that this is a very, very important exam concept, and this is why I wanted to show you. Though the territory is more head and neck than classical brain, but having said that, please remember that this is a very important exam film where they will show you a skull X-ray, a plain X-ray where there might be focal sclerosis of part of the skull. Now, focal sclerosis, one of the differential for that is a meningiomas, and this is more common around the what we call the temporal bone. But having said that, once you see this case, then you can understand what happens. Actually, what happens is the original meningioma is within the intracranial cavity, which is here, and the meningeal cells actually they infiltrate the bone and they can come out on the other side. And there is a secondary response to it, which is because of which there is hyperostosis. So once you know this, then all is fine. So this is hyperostosis due to a meningioma. From StatDX, just to show you the concept, this is the temporal bone, and what happens is that this is a meningioma, which has, now you can see enhancement within the bone. And you are worried, why is there enhancement? Actually, the meningeal cells, microscopically, they go inside the bone, and then they will cause this sclerosis. Okay, candidate 1, thank you very much. And candidate 2, if you can raise your hand, please. Candidate 2, are you with us?
Hi. Yeah.
Okay, now I'll explain to you one finding and then I'll hand it over to you. Now, this patient is a 42-year-old female. The patient had previous cerebellar surgery 8 years ago. We can see a flare sequence at T1, a T2, a post-contrast T1 sequence. And this time we have also done spinal imaging. So we have got T2, another T2, then post-contrast T1, post-contrast T1, post-contrast T1. Of course, these are not fat saturated, but whatever you have to see.
Hello? Sorry, I've lost you here.
See on these non-fat saturated sequence. So over to you. Candidate 2, could you hear me?
Yeah, I lost you for a couple of seconds, I think 3 seconds, but yeah.
So what have you heard till now?
So patient has had a cerebellar surgery and then you were explaining the sequences. So the last sequence, sagittal one, is post-contrast T1 you mentioned. Last 3 sequences, I think, 3 or 4 sequences of post-contrast.
Right. So so these are post-contrast sequences.
Yeah.
And they are not fat saturated, but whatever you have to see, you can see without fat saturation. So over to you, please.
Okay. So I can see on the top left of the screen, there is a low in T1 signal intensity at the periphery of the left cerebral hemisphere. And it's not enhancing on post-contrast T1 images, while on T2 sequence, it's showing hyper-intense signal. On sagittal sequences, there are foci of expanded cord, intramedullary cord lesions, which are T2 hyper-intense. They have got kind of shelf-like or low T2 horizontal signal intensity within them, like levels. There's another on the last 3 sequences, spanning through the whole of the spine. I can see there are multiple lesions at the level of thoracic vertebra, as well as in the lumbar vertebra as well. These are intramedullary lesions, which are slightly hyperexpanding, and they are enhancing post-contrast. So my understanding of this presentation is patient may have had a surgery for intracranial tumor, and now we may be dealing with some. There's also, I forgot to mention, there's also a kind of leptomeningeal nodular enhancement at the level of 2, 3, 4, 5 C5 level on the posterior thecal sac. So we may be dealing with intramedullary tumor as well as leptomeningeal seeding from a previous tumor which was resected.
Right. If you see here, this is a case which tells you a story. Mm-hmm. And the story, of course, is that there was a lesion here. Now, this is what we call cystic cerebromalacia, a portion of CSF with some gliosis surrounding it.
Yeah.
And you picked up very well that there is no enhancement, so there is no tumor recurrence. But then what is happening? There is a long segment, complete abnormality of the cord. Part of the cord has got high signal. And then there is a syrinx here. There is a long segment syrinx. If you go to the post-contrast sequence, you can see one nodule enhancing here, another small nodule, another small nodule, and then there is another nodule. So there are multiple nodular tumors there. And with that, there is posterior scalloping. If you see here, there is a posterior scalloping. So means tumor which is long standing. And incidentally, with that, we can see that the patient is also pregnant. You can see a baby sitting here. So this is a case of von Hippel-Lindau syndrome. And basically, these are multiple hemangioblastomas. And one learning point here is about the appearance of serings. Now, serings, of course, can be what we call primary or idiopathic serings, which is without any cause, but serings can also be because of some other associated reason, such as a tumor. So in this particular case, if you go back to your anatomy, then you can make your radiology. And this is, for example, this is another case. You can see this shelf-like opacity here, another one, another one, another one. If you go back to the anatomy, actually what is happening is that these are denticulate ligaments. We have got 21 denticulate ligaments, which are the ligaments which anchor the arachnoid with the pia mater, the dura mater. Arachnoid with the, the pia mater with the dura mater. And when there is expansion of the cord, then they will appear like this. So these are the denticulate ligaments. The definition of von Hippel-Lindau syndrome is 2 or more hemangioblastomas of the CNS, or 1 hemangioblastoma with 1 visceral manifestations, or 1 central or visceral manifestation plus history of first degree relative having the same disorder. So this is the definition. And the visceral manifestations, which you must remember, include renal cell carcinoma, pheochromocytomas. There can be islet cell tumors of the pancreas. There can be multiple cystic tumors of the pancreas, but there can also be true cysts of the pancreas with true cyst of the liver and spleen. Retinal capillary hemangioblastomas, all of these things are in the head and neck territory. So in the orbit, retinal capillary hemangioblastomas, then temporal bone endolymphatic sac tumors, and there can be glomus tumors in head and neck. Some of these things we'll cover in our head and neck session. In your new Chapman, on page 639, there are details here, and it's a very good idea to read this, because you will get, in your exam, you can get long cases, and if you know these concepts, then you can make a unifying diagnosis out of it. Von Hippel-Lindau syndrome is an Aunt Minnie type of case. It has come in the exam so many times, and still it does come. So unusual presentation of the same case, you have to always remember it. So candidate 2, this is some selected shots of a case of selected images of a case of von Hippel-Lindau syndrome. I will point out and you will tell me what is this. So what is this in the orbit, which is also here? How will you call it?
So in orbit, they can also have hemangioblastomas, von Hippel syndrome, VHL. So these are orbital hemangioblastomas.
Excellent. If you go back to your Chapman, it tells you hemangioblastomas cerebellar are more common, then retinal, then spinal cord, then brainstem. So this can happen within the orbit also. And literature at times uses the word hemangiomas for the same thing. In Chapman, we are using the word hemangioblastoma. It's the same thing. I think just consider them synonyms. Now, what is this? Candidate 2?
This is spinal intramedullary hemangioblastoma.
So hemangioblastomas, please remember, they can be intramedullary and they can be extramedullary also. Second thing in hemangioblastoma is very important for you to remember. Classically, hemangioblastomas will be cystic lesions with an enhancing nodule. If you go back to the earlier case, which we saw here, so there are some cystic components, and with that, there is enhancing nodule. But there can be other presentations of hemangioblastomas. Hemangioblastoma might be just an enhancing nodule. So don't confuse if you see this kind of manifestation. But whatever it is a very vascular tumor, and so vascular that it can be picked up on a DSA, a conventional angiogram also. So this is a hemangioblastoma, this is a hemangioblastoma. What is this candidate to?
This is a large, I think, renal cell cancer.
Okay, so you're right, because you don't know anatomy wise. I've just given you one slice, but actually this was a large adrenal lesion.
Okay.
And which was a pheochromocytoma. And then you can see this cystic lesion in the pancreas, and this cystic lesion has got calcification, some lobular edge. So this is a serous cyst adenoma. Please remember that in von Hippel-Lindau syndrome, there can be cystic tumors such as serous cyst adenoma. There can be true cysts also of the pancreas, and there can be islet cell tumors also. So if you see pancreatic lesions common cysts, usually multiple, unlike most other pancreatic cystic lesions, these are true benign epithelial cysts. They can happen. Then neuroendocrine tumor, which are hypervascular masses, they can happen. Then serous cyst adenoma with the central scar, they can also happen. So many pancreatic lesions can happen. Candidate 2, over to you. So, can you name the procedure?
Yeah, this is a selective intracranial digital subtraction angiography.
So, which kind of angiography it is, and what are the findings?
So these are intracranial angiogram, DSA, and the findings, I can see the on the anterior aspect. There are multiple small aneurysmal dilatation from the branches of the, for example, anterior cerebral artery. Also on the posterior aspect, in the posterior circulation. So I can see at least five aneurysmal dilatation. So there are multiple.
Is it aneurysmal dilatation or something else? Better word to use for it. You can actually see the vessels through it.
Yeah, these are more masses with the hypervascular lesions.
Right. So what can it be?
This could be hypervascular hemangiomas, since they are very vascular. So in the context of VHL, we are dealing with these could be multiple hemangioblastomas or hemangiomas. So
Right.
it's very vascular.
Okay. First of all, before your exam, you must revise your vascular, DSA anatomy. DSA still comes in the exam, and you have to, when a DSA comes in the exam, DSA has got various kinds of standard view, AP view, lateral view, oblique view. And you can get confused what exactly has happened. So you have to.
Hello? Hello?
What is this? What is this? That kind of a vulva will always happen. And that is why my advice is to look for, revise it before the exam. Now, this is a vertebral artery angiogram, and there is cross-filling from the other side to the other side. And you can see what we call multiple tumor blush. So the word here is tumor blushes. And these are very vascular tumors. And these very vascular tumors, of course, we are doing von Hippel-Lindau. So So this was one Hippel-Lindau, and you can see that multiple on these limited sequences, you can see that there is an enhancing nodule, and this one has got that cystic component which I was elaborating. So this is more classical. So there can be just nodule, there can be nodule with usually a cystic component. You can see the cord has got a lot of edema, cystic component, and there is a nodule here also. And again, multiple cysts in the pancreas. So another case of VHL. Okay, candidate 1, candidate 2, over to you.
So it's a 5-year-old. It's MRI axial slice, selected axial slices, a 5-year-old. So sequence-wise, we're dealing with so white matter is white on the left, but the CSF is also bright. So we're dealing with T2. On the right, this is.
So what is this sequence?
So this is flare sequence.
Okay, very good. So over to you. What are the findings?
So there are multiple areas of hyperintensity, especially in the cortex of the posterior fossa and occipital lobes. There's also some areas of hyperintensity subcortical in the right anterior frontal lobe. So there are patchy asymmetrical hyperintensity basically bilaterally, mainly in the areas of subcortical region. It probably involving the subcortical new fibers.
So what is happening here? And which is also happening.
In the ventricular area. Okay, so basically in the ventricular there are subependymal nodules, which I can see in the flare as well. They are high attenuation, high signal intensity. So these are subcortical tubers, which are hyper intense flare signals, and also in the T2 weighted sequences as well. So we are dealing with a case of possible tuberous sclerosis, where I can see the subcortical tubers and some ependymal nodules. On the last sequence, there's also within the right lateral ventricle, there's a gray intermediate signal intensity lesion in the frontal horn of the right lateral ventricle. I would be keen to see it in the post-contrast sequence to see whether there's enhancement or not to rule out SEGA, subependymal giant cell astrocytoma.
So what is the location of subependymal giant cell astrocytoma usually?
It's within the ventricle, and it's subependymal. So
where in the ventricle?
It's in the frontal horn. It can be in trigone as well, but mainly in the frontal horn.
Okay, let me take over now. The point is, the findings on this is, once you know your pathology, you can make your radiology. So this is, of course, a case of tuberous sclerosis, but the key finding is this subependymal nodule. Now, in tuberous sclerosis, there are basically, these are hematomas, and the hematomas can be at multiple locations. They can be subependymal, which is pathognomic. Once you pick it up, you pick up the case. Then there can be similar findings in the white matter, and then in the gray matter also. Once you know this, you can make your radiology. Now, the giant cell astrocytoma, which you have referred to, the classical location is foramen of Monro. And foramen of Monro is where two lateral ventricles, they drain through it into the third ventricle. So that is the classical location. So this is a case of tuberous sclerosis. Now, another case for you, candidate.
So these are selected axial slices through the brain, MRI. On the left, extreme left, we are dealing with T1 here. Then T1, then flare, T2, and this last sequence is it flare again? White matter is dark here. So
this is a PD weighted sequence, and how do you pick up that this is a PD? In the formula is that on a PD weighted sequence, CSF is equal to gray matter. So the vessels, which are these leptomeningeal vessels, they will appear as filling defect. So this is a PD, this is a T2, this is a flare, this is a T1. Over to you.
So again, I can see there are multiple areas of multiple subependymal nodules. However, which I can also see. I'm trying to look for any Sega here. I can't find Sega, but definitely there are multiple subependymal nodules. I cannot see any subcortical tubers or hypertensity in any of these sequences. I can see a focal area of hyperintensity in the PD, just lateral to the frontal horn of the right lateral ventricle, which is hyperintense in all the sequences, more or less. But the quite prominent finding is quite enlarged multiple subependymal nodule, to the extent that they're quite chunky. So these are not classic location of Sega, but I will still consider post-contrast images here to find any enhancement, because they look quite irregular and quite enlarged within the ventricles.
So what is your conclusion?
I'm thinking about tuberous sclerosis, so I would like to scan the rest of the neural axis to look for cortical tubers, Sega on, and the patient needs to be referred to have a chest X-ray and an ultrasound of the abdomen to begin with, to look for angiomyolopomas and LAM.
Right. So first of all, in the exam, don't use this word Sega. Sega, you know what is a Sega. You just use the whole word, whatever you want to elaborate. Second thing is that anatomy-wise, you are not seeing the foramen of Monro here. So you can say that I'm not seeing the foramen of Monro, but here this is not the location for it. But the key thing here is that I had put this case intentionally, because this is what has happened in the exam for many students in the past. You pick up something in the subependymal world and you then convince yourself that this is tuberous sclerosis. This is not tuberous sclerosis. The key thing here is that this is subependymal heterotopia. What is happening here is that if you see these nodules, they have got signal intensity equal to the gray matter. So look at on this T1, it is equal to the gray matter. On this flare, it is equal to the gray matter. On this T2, equal to the gray matter. And on PD, you don't see it, because again, it is equal to the gray matter. The concept of heterotopia is that in a developing fetus, the gray matter, the cortical cells, they arise or they develop from the periventricular germinal matrix, and from there they migrate outwards. We will see more cases of it when we do congenital. Here they have arrested, and the location here is subependymal. They can also arrest within the white matter, like, for example, this particular nodule you were referring to. But at times they arrest here in the cortex. We will see them subsequently. And please remember, this case also has come in the exam as a CT scan. I'll show you later on in the congenital. And it becomes, the eye sees what the mind knows. If you don't, so this should be a sort of a review area for you to see the subependymal, region. So here, just if you go back, the subependymal nodules of tuberous sclerosis will not be equal to the gray matter. And please remember that they will calcify. By the age of 2, they do calcify. On a CT scan, it becomes a very easy call. But on an MR, you might miss it. So this was a sort of a trick case which I put up here intentionally. So subependymal tuberous sclerosis, this is the definition. Some of these things are not for your exam, but few of these you have to remember for your exam. Please remember in all the phacomatoses, there is or there can be involvement of the orbit. So similarly here, there can be retinal hematomas, cortical tumors, subependymal nodules, subependymal giant cell astrocytoma, cardiac rhabdomyoma, single or multiple. This has come in the exam. This is, the most common cause of rhabdomyoma in a young age. And it can come as a long case also. When you see this, then you have to look for lymphangiomyomatosis, which you will see some cases in our chest module. And then there is renal angiomyolipoma. And renal angiomyolipoma, of course, will have some fatty component. This is from your book, Tuberous sclerosis. And it's a good idea to read it from here. And you can make your long cases from here, particularly cardiac rhabdomyoma and this lymphangiomyomatosis. So other than that, kidney lesions are also important, particularly angiomyolipomas. So this is a case in which you can see, these ones are calcified. This patient was, of course, 42-year-old actually, and there are multiple fatty lesions in the kidney, angiomyolipomas, and this particular patient also had similar lesions in the liver, which is a bit rare, but it can happen. Henriette, over to you.
So it's a selected MRI slices of a 12-year-old patient. I can see on the top left, this is the one sequence, top two sequences on the left, and then we've got.
So this is a T1 pre-contrast, sagittal T1 pre-contrast. This is post-contrast. This is a T2, another T2. This is post-contrast, post-contrast, post-contrast.
So there's a high flare signal intensity located at kind of foramen of Monro, which is on coronal T1, which is T1 isointense. Both frontal horn of lateral ventricles are slightly, they're symmetrical, but they look very prominent for 12 years old patient. On sagittal pre and post contrast, it's enhancing quite avidly, and I cannot see any hydrocephalus because the fourth ventricle is quite normal sized as well. On T2, there's a mixed signal intensity. This particular lesion is demonstrating quite mixed signal intensity. So my differential here, there's also I can see a subependymal nodule on the second last sequence.
So what is your conclusion?
So my conclusion here is we are dealing with a case of tuberous sclerosis with subependymal nodule and subependymal giant cell astrocytoma, which is avidly enhancing on post contrast images. I'm just looking at this last coronal sequence, and just the area looks very busy in the region of cochlea and intracostomatus. So I was wondering whether we are dealing with some endolymphatic lesions as well or not. Although thinner slices would help to have a look at them quite closely.
Okay, so there is nothing there. As you have picked up, this is, you can see subependymal nodule here. You can see then on this T2, you can see high signal here in the cortex, in the white matter. Everything is explainable. So this is the classical location of foramen of Monro and the classical location of giant cell astrocytoma. So this is from your book. This is in the peak section 14.74, intraventricular mass in the children. They were divided it into solid mass and then is the cystic mass. And as far as the foramen of Monro has got specific differential diagnosis: subependymal giant cell astrocytoma and central neurocytoma. So we will revisit these. Many of these can be seen in the adults also, and there are less changes in this category as far as peds and adults are concerned.
This is,
yes, please. What is this?
Yeah, this is axial CT, non-contrast, which is demonstrating calcified subependymal nodule, and there is a large, slightly dense lesion in the anterior horn of the right lateral ventricle, which is looking very prominent as compared to the left side. There are also some, I'm not sure whether it's projecting, but some subcortical frontal lobe hyperdensity, but I'm just trying to make it out or not. But from the appearance of this lateral ventricle, I'm wondering whether these are calcified subependymal nodule, and this large lesion arising from the subependymal surface of right lateral ventricle looks quite aggressive. It's not calcified, so this could again represent an atypical location, a presence of subependymal giant cell astrocytoma in an atypical location rather than the phenomenon of Monro. So these are the MRI sequences of the same patient on the post-contrast images on the top two left-hand slices, coronal axial. It's demonstrating avid contrast enhancement. There's a flow wire in it, which showed probably the vascularity. And on flare, on T2 sequences, basically, it's a mixed sequence with some flow words in it as well. There are subcortical tubers as well on the flare sequence. So these findings are quite again suggestive of tuberous sclerosis with subependymal nodule, subcortical tubers, and subependymal giant cell astrocytoma.
So the point is that this is again the same location. It's a large lesion, so it is projecting superiorly. It can project inferiorly also. Otherwise, just to make the point that you can see the cortical hematomas, you can see the white matter changes. Of course, you can see the subependymal nodules. Some of these are calcified.
These are selected slices MRI, axial and coronal, or 18 months old male. On the T1 sequence, on the extreme left, there is atrophy of the right cerebrum or cerebral hemisphere with probably reactive dilatation of this lateral ventricle, slight lateral dilatation. There's also a ribbon-like cortical enhancement. Is it a post-contrast sequence on the middle one?
Mm-hmm.
Yeah. So the cortical ribbon-like enhancement of the cortices of this small right cerebral hemisphere. I'm just wondering whether these are old deposition of old blood or there's some increased vascularity in the meninges as well. So I'm just wondering whether we are dealing with some vascular disorder with with insert to the brain, resulting in the microcephaly on this one side. And for example, in Sturge-Weber syndrome, you get this cortical hyperdensity enhancement.
Why will there be enhancement?
I think the concept was increased vascularity, and probably there was some old blood hemosiderin deposition, and I'm just I think mixing the two concepts up. But the pattern recognition is more of Sturge-Weber syndrome.
Okay, now, candidate okay, you can still be with us. I think this is the last case before the break. Last pathology, and I'll show you one or more case of this. Basically, if you go back to Sturge-Weber syndrome, the concept is that leptomeningeal angioma, and there is basically a venous malformation type of a thing sitting on the leptomeninges, and because of that, if when the baby is let's say less than 1 year old, if you give contrast, it will enhance, it will give you this kind of a picture. But the key concept is that what is happening, that there is a bit of vascular stale phenomenon going on. So because of that, there is developing atrophy of the brain. And after a while, after some months or years, what will happen is that there will be atrophy, and there will be then calcification. And that calcification comes in the exam, because that calcification is classical, what we call barrel pattern of calcification. And so here, what is happening is that there is atrophy and there is enhancement. If you see here, how will you describe this finding, please? Over to candidate 2.
These are quite serpingeous, hyperdense shadows or projection or densities projected over the whole skull, just like vessels, blood vessels, like you get in Hemangioma. And also these are very calcified as well. This very high density.
You know, this pattern is an Aunt Mini. There is nothing else in the world which will give you this appearance.
Port wine hemangioma.
This is not hemangioma. This is cortical, gyriform calcification, which is absolutely pathognomic for Sturge-Weber syndrome. And on this lateral also, it gives you this gyriform calcification. So nothing else should give you this kind of appearance. In our case, there is actually bilateral, but on this side, it is more than on this left side. It's a different case, but just to highlight the findings that it can be, this is that gyriform calcification, which we were talking about. Right. Candidate 3. Now, there is a tumor here. And this is a T2 weighted sequence, T2, T1, post-contrast, and post-contrast. Now, question to you, is it intraaxial or extraaxial?
So there is an outline of kind of hyper intensity on the T2, which is consistent with a kind of CSF cleft.
Excellent.
So
intra or extra?
This is extra axial.
Excellent. So in the exam, so please remember this session is all tumors, and today we will just cover tumors and nothing else. As I told you in the beginning also, that first 2 sessions, the pace is going to be slightly slow, and today also the pace is going to be slow. But next 2 sessions in which I will finish CNS, the pace will be more quick. There will be, again, today's session, again, we will do a bit of differential diagnosis. In CNS, the most important differential is in the tumor world. And anatomy is again the king here. So we will refer back to anatomy again and again. So when you see a tumor in your exam, you can completely go to a wrong direction if intra versus extra axial, you get it wrong. So if you see here, there is a cleft of CSF in between the tumor and the brain parenchyma, and this cleft tells you that this is an extra axial lesion. Now, this is a very tricky one, where you see a lesion here, there is a bit of edema, it enhances, and here also it enhances. You are not very sure what is happening. If you look here on this sagittal sequence, parasagittal, you can actually on a T1 weighted sequence where I am pointing out, you can see a bit of low intensity cleft there. So sometimes even on a T1, you can make up your mind. And the take home point is that you might like to see all planes before you, in difficult cases, before you make up your mind. But sometimes you can make up your mind just on the first sequence. Just a bit of recap of the basic concepts of brain tumors. There are 4 histological parameters. This is the WHO classification of brain tumor 2007. It was upgraded in 2016 where they use molecular markers. Most of the people, particularly people like myself, I don't work in a neuroradiology setup. We just stick to the old classifications. And old classification based on histological parameters. So the histological parameters include nuclear atypia, mitosis, microvascular proliferation, and necrosis. So the definition is that, grade 1, grade 2, grade 3, grade 4. If grade 1 is just a circumscribed astrocytoma, but grade 2 is one of these parameters can be seen histologically. Grade 3 is 2 parameters, grade 4 is 3 or 4 parameters. So this concept of grade 1, grade 2, grade 3, and grade 4 is an important concept in radiology and a useful concept also. Grade 4 tumor is what we call a GBM, a glioblastoma multiforme, and it will have necrosis, will have cystic spaces and things like that. So it is an important concept, and I'll refer back to this wherever we have to. For example, a grade 1 tumor might not enhance. The blood-brain barrier is not broken. It's a low-grade tumor. So it can happen. For example, a optic glioma might be a grade 1 and might not enhance. On the other hand, it might enhance, and then comes this concept of many of the brain tumors, they can convert from a low grade to a higher grade. So a low grade astrocytoma might convert to grade 3, and ultimately to grade 4. So all of these concepts are important to remember, particularly in your day-to-day radiology. Now, the differential diagnosis today in this session, in the next 2 hours or so, we will just cover differential diagnosis of tumors. And the key thing in tumor is location. So in your book, there are differential diagnoses. If there is a tumor in the sella, we call it sellar tumors, suprasellar, infundibular, cavernous sinus, CP angle, things like that, posterior fossa. So location changes the differential diagnosis. And then age is a critical, factor. Just like bone tumors, if you remember bone tumors, age was very important. So in the same location, if it's a child, the differential might be different. If it is an adult, the differential might be different. And then if you know the radiological features and sometimes the clinical features, in some of the tumors, the clinical features are very important, then you can really give a final diagnosis. In the exam cases, as we will learn today, the differential diagnosis, you might like to give 1, 2, 3, not more than that. There will be many cases in the exam where you might like to give one final diagnosis quite confidently. The examiner might grill you and might ask you what else can it be, and they are trying to see your thinking. So you can, tell the rationale that why you have considered X differential and why it is unlikely to be what it is. So that is the concept which we will cover in this session. Okay, as an example, I am going to go through a single case, and then we will step up and go through, quickly. But this is what is going to happen in the exam. So candidate 3. This is a T2 weighted sequence. This is a T1 weighted sequence. What is the abnormality? And where is the abnormality?
There's midline hyperintense lesion within the suprasellar fossa.
Excellent. So what has been picked up is that this is the midbrain, and anterior to the midbrain is the suprasellar cistern, and this is the interpeduncular cistern. Something is sitting there. So please remember that this can happen in the exam, where an examiner will open a axial sequence. Once you pick it up, then it is your right to ask for other sequences. So these are the other sequences. And my question is that this is a T2, this is a T1, this is a T1, this is a T2 coronal. What is the location? What are the radiological features till now? What is the epicenter of the mass? What would you like to see next?
So this is a definite separate to the pituitary and is in the suprasellar region. It appears to be potentially I think that this patient might have gelastic seizures potentially. Is it in the mammillary bodies? It's anterior, yeah.
So your thinking process is that you are, I am trying to listen for anatomy words because your thinking process is perfect, but you use the word suprasellar cistern, then you were thinking aloud about the clinical, you might not be wrong there, but right now, my question is epicenter. Can you describe the epicenter in anatomical terms? Can you describe the findings? How is it on T1? How is it on T2?
So it's iso-intense to cortical grey matter on T2. It's so it's basically iso-intense to grey matter on T1 and T2, and on flare it's slightly. No, it's still the same. So it's iso-intense on all sequences. So, and I don't have a post. Do I have post contrast?
So what is the location?
I would like a post contrast T1 series.
Okay, I'll give you a post contrast. What is the location?
Scratching my brain. It's the beak of the hummingbird.
So
Must be
the
the
hummingbird is
no, it's gone. My brain has gone.
okay. So the point is that, as I have pointed out in the beginning, that this case I am going to teach all of you that what are the skills to pick up a brain tumor and how at which level you have to take it to be able to give a differential and an exact diagnosis. Anatomy is the key. So right now, we have picked up a lesion, which is, as you have pointed out, you want to give contrast, fine, but anatomy-wise, the fine touch, where is it? So we'll revisit this. Now, on post-contrast, it does not enhance. You see here, it does not enhance. So, what is your differential then?
So it doesn't enhance. It could be a colloid because it's kind of facing the third ventral. It could be a colloid cyst. It's not enhancing.
But the colloid cyst is usually at the foramen of Monroe.
Yeah, true.
That is usually high signal on a T1 weighted sequence. Here, anatomy is the key. Where is it? Right, okay.
So it's a hypothalamus, isn't it? It's a hypothalamic hamartoma, potentially.
Okay, very good. So let's go back to the anatomy. So if you see here, this is the pituitary gland. This is the anterior pituitary. This is the posterior pituitary. The anterior pituitary rises, embryologically speaking, from the roof of the mouth. And the posterior pituitary actually is an outpouching of the diencephalon, so it is from the brain. Now, this structure here is the infundibulum. Each and every structure here has got a different differential diagnosis as far as brain tumor is concerned. So you have to be very careful and you have to know the fine touch. Now, this area here is the floor of the third ventricle. And in the floor of the third ventricle, this is the optic chiasma, this is infundibulum. From here till here is the hypothalamus. Hypothalamus has got various components, some of which are not seen, distinctly on imaging, but the words are tuberous cinerarium. So this is where I am pointing out somewhere here is the tuberous cinerarium. And this word is important for you because hypothalamic hematoma, as you have pointed out, your diagnosis was correct, is also known as tuberous cinerarium hematoma. Then there is something here which is known as anterior perforated substance, posterior perforated substance, nothing to do with radiology. Mammillary body here, and then is the midbrain here. And this midbrain has got posteriorly the tactile plate, superior colliculus, inferior colliculus. This is the aqueduct. This thing here is the pineal gland. And there are two commissures here, the posterior commissure and the habenular commissure. Not important for you in FRCR level. Pineal gland is very important, by the way. And you can see that this is the corpus callosum and the rostrum, the genu, the body, and the spleen. So this part of anatomy is very important. You can imagine that if a slice goes like this, it will go posteriorly with the midbrain, then there can be the suprasellar cistern, but also the hypothalamus can be there. If a lesion has got epicenter in the hypothalamus, which is the floor of the third ventricle, superiorly it will project into the third ventricle. So same on a cis-sagittal sequence. I showed you this anatomy in the previous session, but just a recap. This is a cis-sagittal sequence. This is the pituitary. This is the infundibulum. This is the optic chiasma. From here to here is the hypothalamus, the memory body here. And this is the pineal gland. This is the midbrain. This is the tactile plate, the aqueduct. I also showed you last time the recesses. This is the infundibular recess, and this is the chiasmatic recess of the third ventricle. Superior to the pineal is the suprapineal recess. So this is the anatomy. Of course, the corpus callosum is there. Now, in your book, there is a differential diagnosis of suprasellar masses. So you have to actually master this part for your exam, where the suprasellar masses, particularly the important suprasellar or exam suprasellar masses, which I'm going to show you today, you have to understand the radiological features, and then considering age and at times considering the clinical, which the examiner might tell you, you can make a specific differential. And some of the cases you might not give a specific differential, but at least one or two. So suprasellar masses, meningiomas, very important. Granulomas. So granulomas, for example, sarcoidosis, TB, extremely important. Aneurysms can be there. Now look here, parenchymal, pituitary lesion. Now pituitary lesion per se is a differential diagnosis. And then infundibular masses. So these are the masses which arise from the infundibular. If you do not make up your mind what is the epicenter, you will not go into the fine touch. Then look at these, hypothalamic hematoma. This is what your case is, by the way, so your diagnosis is correct. But how did we reach this? This is what I am trying to elaborate here. Then there can be germ cell tumors, there can be metastasis and lymphoma. And there can be lesions arising from the optic chiasma, like chiasmatic glioma. And then there can be lesions which are sitting in the C subspace, like epidermoid, dermoid, teratoma, lipoma, and arachnoid cyst. Now, to take it further, if you go back here, infundibular masses was there. And now there is a differential of infundibular masses itself. So, the fine touch is extremely important. So, and look at these metastasis, lymphoma, leukemia, craniopharyngioma, Langerhans cell histiocytosis, non-neoplastic neurosarcoidosis, extremely important for your exam. So we will come back and back to these differential again and again. Now, look at the clinical input. Clinical input is that this is 8 years old. But if you go back to your anatomy and make up your mind what is the epicenter, look at the pituitary gland. The pituitary gland is normal. The mass actually is arising from the floor of the third ventricle, which is the hypothalamus. And it is projecting superiorly here into the third ventricle. Also, you can see here, it is slightly exophytic, so inferiorly it is extending into the suprasellar cistern. Doesn't change anything. The signal intensity is equal to the gray matter. It is on T2 as well as T1 with its sequence. It does not show any enhancement. Quite unique imaging features. With that is the clinical precocious puberty. So these are children who might start menstruating at times at 2 years of age because of this hematoma. It's a migration disorder actually. And so these are this in a young age group in a child This will be our differential diagnosis. Craniopharyngioma, hypothalamic glioma, germinoma, and hematoma of the tuber synovium, or hematoma of the, or you can simply use the word hypothalamic hematoma. Now, look at the differential diagnosis. At the radiological features. Craniopharyngioma can have various kinds of imaging features like cystic component, at times just solid component. It can be sellar, it can be suprasellar, it can be sellar as well as suprasellar. It can have calcification, but it will have some enhancement. Unlike this, if there is a glioma, again, it will enhance. It is not like that, and it is not arising from the optic nerve. Germinoma will enhance. So, hematoma of the tumor synovium is the only differential. So, this is the type of case in which, in the exam, suppose you get it, then you have to satisfy the examiner that why is it hematoma of the tuber synovium, what is the differential, and the examiner might grill you, and you can tell the features which we have just discussed. There is nothing else like this which will have imaging features like this with anatomical features based at the hypothalamus. So the key points about tuber synovium hematoma is that basically it's congenital heterotopia. The patient can present with precocious puberty. As I told you, maybe at 2 years old, a child can start having menstruation. Sometimes they will have seizures, which is known as gelastic seizures, where the child has got these, laughing type of episodes. This is the basis of it. And classical location, which is, as we have elaborated, size can be at times large, up to 4 centimeter. Iso-intensity 1, iso to hyperintensity 2. No cystic component, no enhancement, no calcification. So, there is nothing else. So, in this particular case, we can actually give a final diagnosis. So, you have to really take your, skill level to be able to reach and give this type of or tackle a case like this in the exam. Okay, candidate 3. Now, this case came on a CT scan. The patient presented with, some kind of tumor. They passed a shunt. So it is a bit, the hydrocephalus has reduced. So this is post-contrast, pre-T1, pre-T1 flare, and T2. So over to you.
Okay, I'm presented with an MRI.
Excuse me, and this patient is 4 years old.
Thank you. I'm presented with a pediatric brain MRI of a 4-year-old patient who has been decompressed. There is a posterior fossa tumour that it has its epicenter in the midline within the 4th ventricle on T2 sequences, iso-intense to cortical grey matter. On T1, it's hypodense and it avidly enhances. On post-contrast sequences, there is also dural or leptomeningeal enhancement in the posterior fossa on post-enhancement imaging. There is the impression of there is an additional lesion in the pons with similar characteristics, signal characteristics to what I've described, although I don't have the pons on view on my post-contrast images, so I can't comment on contrast enhancement there. So in summary, I've got an aggressive posterior fossa mass in a pediatric patient. It's centered on the midline rather than to the side. There's not a cystic enhancing nodule, so less likely to be a pilocytic astrocytoma. It's in the midline. I'm just trying. Pontine. There is some pontine involvement, so pontine glioma could be within the differential. However, normally doesn't then involve the ventricle in the same way that this does, and also doesn't normally have dural kind of or CSF seeding. I'd be interested to see on CT whether this was hyperdense or not. The fact that there's lateral extension on the coronal views may indicate that there's kind of expansion and plasticity through the foramen of Luschka, which is typical of an ependymoma. But I think that's more in an adult patient. So my main differential would be.
So what is your conclusion as far as differential is concerned?
I'm concerned that this is a pontine glioma or a glioma.
Okay, so
yeah.
Some of the thought process was good, and some we will slightly elaborate on that further. Now, can I ask you, what is the bookish differential diagnosis of posterior fossa tumors in a child?
Pontine glioma, Meningioma, and a polycystic astrocytoma.
Okay, now this is one of the most important differential diagnoses for your exam. Infratentorial tumors in childhood, from your book. The top 4 is what you have to remember, and you can forget about this one. This is beyond 2B level. Now, if you see the important features of these, cerebral astrocytoma is the most common tumor in childhood, age group 5 onwards. Below 5, medulloblastoma is the most common. Cerebral astrocytoma can have various kinds of appearances. A classical appearance, just remember it, is like a classical hemangioblastoma. And please remember, hemangioblastoma you will not consider in this age group unless very rarely in VHL, and which is a cystic lesion with an enhancing nodule. But please also remember that cerebral astrocytomas can have other features, other appearances. It can be completely solid, and it can be solid with a cystic component. Interestingly, some of them, about 20% of them, can have calcification. They arise, 50% from the vermis. They can arise from the cerebral hemisphere also. So these are the features of cerebral astrocytoma which you have to remember. Medulloblastoma is a grade 4. This is a grade 1 tumor, and this is a grade 4 tumor, the worst among them, medulloblastoma. And the classical location is the vermis. It will be a solid lesion. It is the most common below the age of 5. About 10% of them might calcify. They can be high density, as you were pointing out on a CT, but of course, that is not a game changer, should I say. And the concept of CSF drop metastasis is very important for you to remember. Drop metastases are tumors which metastasize through the CSF. And there is a concept of drop up and drop down. So the lesion might go from the brain into the spine. And the viva scenario is that you will ask the examiner that I want to see the spine, whole of the neural axis. So these tumors can show CSF drop metastasis. Then comes ependymoma. Now, ependymoma is some of the things which you were pointing out, candidate 3 were correct. This is what we call a plastic tumor, where this classical location it arises from the floor of the the fourth ventricle. And from there, it goes through the foramen of Luschka and foramen of Magendie. Through the foramen of Luschka, it can go into the CP angle system, the cerebellopontine angle system. Classical teaching is that if you see a tumor at the floor of the fourth ventricle with calcification, call it an ependymoma, but with a pinch of salt, because I told you that 20% of cerebral astrocytomas can also show calcification. 10% of even medulloblastomas can cause this. So a tumor like a medulloblastoma can go into the brainstem, but brainstem gliomas have got various types, something which is arising from the medulla, something which is just arising from the pons or the midbrain. There is a variety which is diffuse involvement, and that comes in the exam. So some of the features which I have told you are, quite pathognomic for various tumors, and you can give a very good differential, and in some of them you can give a single final diagnosis and say that I will still cover X and Y in my differential. So with this background, let's go back to this case. This case, I have given you limited sequences, so you were a bit handicapped, but you can see that there is a tumor sitting, and it is completely actually filling up the fourth ventricle, and that is why there was hydrocephalus. This thing which is sitting in front of pons, actually in front of the midbrain, actually is a drop metastasis, and similarly there are drop metastases right and left. So these are CSF seedlings. And the question will be, what will you do next? And the answer is that I will ask for all of the neural axis, and you can see these drop metastases in the spine also. If you see here, this was that lesion in the midbrain, which is this one, it also enhances. So this is a medulloblastoma. This thing is not given in your Chapman, so you must make a note of this, that tumors which commonly cause subarachnoid seeding, in that which is medulloblastoma, GBM lymphoma, ependymoma. Now this is a grade 4 tumor, but this can also show what we call drop metastasis. Choroid plexus papilloma. Pineal tumors are very important for the exams. Germinoma or pineoblastoma, they will show drop metastasis. One thing which I always add here is do not forget ruptured dermoid. So dermoid is not exactly a neoplasia, but having said that, it has come in the exam many times, and they will show you droplets of fat in the CSF, and there will be nothing sitting in the brain. So you will ask the scan of the spine, and you will pick up the dermoid sitting there. Okay, candidate 3, can you tackle this?
Yep, so I've got a non-contrast enhanced axial CT of a 4-year-old male patient with recurrent vomiting, high BP and bradycardia. There is gross dilatation of the lateral and third ventricles. There is a lesion within the fourth ventricle with calcification. and a small amount of potential edema or hypodensity in the left
What is
cerebellum.
happening here, where I am pointing out?
Trying to look at sequential. So that is, it's a heterogeneous or maybe highly mitotic lesion that has got central areas of necrosis potentially, and areas. So I think that there's areas of soft tissue, and then the areas of hypodensity are.
I am just trying to ask you. Do you see this hypodensity here, like CNS?
Yeah.
So the lesion is here. What do you think is happening here? Anatomy wise, where are we? Do you see this IAM here?
Yes, yeah.
So do you see this potential connection between this? And there is no connection. There should be no connection. Are you with me now?
Yes, yeah, I'm with you, yeah.
So with this hint, what comes to your mind?
So is there synchronous tumours of the fourth ventricle and the IAM? Or is it mass effect so is it a phacocytosis?
No, you see, please, this has to be from the differential diagnosis, which we just considered.
Just spoken about.
Yes. So pick up your choice from there.
Well, the cerebellar astrocytoma, because it has calcification. It's off to so actually potentially not epicenter within the ventricle, as it were, but it's extending into it, so it's from a lateral point of view and extending in with calcification, and that there could be kind of a cystic dilatation around the tumour itself.
Okay, so this is a classical ependymoma.
No.
The tumor is sitting in the fourth ventricle. It has got punctate calcification. Please remember, calcification is most common in ependymoma out of all of these. 50% of them particularly punctate. And you also pointed this out, that these tumors have got behavior. They might pass into the CP angle through the foramen of Luschka. Actually, if you see this on an MR, you will make up what is happening. Actually, there is expansion of the foramen of Luschka, and the tumor is going into this. That is why it is an ependymoma. Of course, there is transependymal interstitial edema, and there is hydrocephalus. Now, this is the lesion. It shows enhancement, and this is what it is. Now, this is a picture from STAT-DX, which tells you what happens, that the tumor can, that is why we call it a plastic tumor. It goes through the foramen of Luschka into the CP angle. It can go through the foramen of Magendie into the cisterna magna here. So if you see this case here, this is a 2-year-old. Here on this CT scan, we can see that there is a bit of calcification. If you see carefully, this is the fourth ventricle. There is something here. Limitation of CT is you are not very sure what is happening. But one thing you can make up, that something is sitting here. It is not very central. With this punctate calcification, and there is hydrocephalus. We do an MR, and on this MR, you can see what is happening. It is going here. It is going into the CP angle. And or even on this T1 pre-contrast, you can make up what is happening, that plastic tumor behavior. So this is an ependymoma. Another case, again to make up the same point, that the tumor, look at this T2, part of the tumor is sitting here. You can see that there is expansion of the foramen of Luschka, and part of the tumor is sitting in the CP angle. So another ependymoma. Okay, candidate 3 for you.
So we've got multiple axial, coronal, and sagittal slices on T1 and then T2 and flare. It's predominantly cystic.
So this is post-contrast, yes.
Okay, so
Cystic tumor with?
it's predominantly cystic lesion with a enhancing peripheral nodule within the right cerebellum with local mass effect. Most likely diagnosis would be a cerebellar astrocytoma.
Okay, very good. So this is a classical, pilocytic cerebral astrocytoma, which has got a cystic component with enhancing nodule. They have got good prognosis, and it's a classical finding. Here, over to you. This is your last case, and candidate 4, please be ready after this.
Okay, so I've got predominantly hypodense lesion in the pons. I think the most likely differential in this case would be a pontine glioma.
Right. So this is the type of glioma which you have to be careful in your exam, and some of these can be quite diffuse. On CT scan, particularly axial, you can see that there is hypodensity, and these lesions, they go up through the tracts, so corticospinal tracts, etc. So this type of lesion you can miss if you are not very careful, because it will cause diffuse findings. Our case on an MR becomes quite easy to pick up. Right, candidate 3, thank you very much. Candidate 4, are you with us?
Thank you.
So candidate 4, I am going to unmute you.
Yes, sir.
Okay. This anatomy we have already covered. On a coronal sequence, a bit of anatomy, because we are now going into the differential diagnosis of cellar, suprasellar, cavernous, sinus, infundibular, all of these things. If you see, this is a coronal section. This is the pituitary gland. This is the infundibulum. On the right and left is the cavernous sinus. Within the cavernous sinus is the cavernous portion of the internal carotid artery. And this is, by the way, a viva question, which has been asked in the viva: which nerves pass through the cavernous sinus? And just to revise, that third nerve, fourth nerve, 2 branches of the fifth nerve, and the sixth nerve, they pass through the cavernous sinus. And which 2 branches of the fifth nerve? The V1 and the V2. And V3 does not pass through it. We'll come back to this point. And superior to the this is, of course, the optic chiasma. This is what we call the supraclinoid portion of the internal carotid artery within the suprasellar cistern, and it will divide into ACA and MCA. Please remember, all of these have been asked in the exam. So the examiner will put the mouse on some part of anatomy. What is this? What is this? What is this? Another point which I want to elaborate is that inferior to the pituitary gland is the sphenoid sinus. And a large pituitary macroadenoma which goes into the sphenoid sinus, that is also an exam case. So if you see here, this is the pituitary, this is the infundibulum, which enhances with contrast. This is the sphenoid, this is the clivus. On a coronal sequence, you can see pituitary here, cavernous sinus here, cavernous sinus here, internal carotid, internal carotid. What are the signs of invasion of the cavernous sinus? I will come back to that point. So this kind of anatomy can be asked in the exam, where the examiner might put the mouse here. What is this? And this is the supraclinoid portion of internal carotid artery. What is this? And this is the ACA. What is this? This is the MCA. Okay, candidate 4, over to you. 4 years old.
Okay. So I'm provided with the multi-sequential images of MRI, sagittal and axial slices, and which I can see there is a heterogeneous lesion involving the suprasellar region, mostly involving the pituitary fossa. So it's like partially cystic, as well as there is some solid component. And I can see there is some hypo-intense areas, also with surrounding edematous changes, edema. So I can see there is a prominence of the temporal horns as well. So this shows this compressing and is causing the hydrocephalus. So in the 4-year child, my differential is craniopharyngioma, or it could be a pituitary macroadenoma.
Okay, I'll stop you here. Pituitary macroadenoma, can that happen in a 4-year-old?
No.
No. So this is, you see, the point is that once you pick up a lesion and you know the age of the, just like a bone tumor, the differential diagnosis will be different. And please also remember that a pituitary macroadenoma, radiologically speaking, will not be like this with, this huge cystic and component, as well as going superiorly like this with enhancing. And this particular lesion also has got a bit of calcification. You can actually ask for a CT scan, because in your clinical practice, what is happening is that many of these patients will have a CT scan in any case as a first, investigation. So because it's a child, you can ask the examiner that I would like to see a CT if it is available, to see for any calcification. And 90% of craniopharyngiomas have got calcification. Please also remember that craniopharyngiomas have got 2 peaks. Till the age of 15 is one peak, and second peak is in the 5th decade. Somebody who is 50 to 60 years old is another age group in which they can happen. So you can see that it is sellar, it is suprasellar, it is going into the projecting into the third ventricle, it is compressing the midbrain, it is causing hydrocephalus. CT scan has got calcification. Just to make a point that this is a 56-year-old similar lesion to the one which we saw, and this was a craniopharyngoma, but the age group is different. So this was a craniopharyngioma. Now, candidate 4.
Okay. So on T1 axial slices and right brain images, I can see there is fluid. There is a flat fluid level involving the pituitary region, and I suppose that there is pituitary macroadenoma, which shows some hemorrhagic changes. So, and rest of the, I can't see any intraparenchymal bleed or any other lesion, similar lesion. So on the sagittal, I can see there is also that level, which confirms that there is some hemorrhagic infarct or of the pituitary macroadenoma of the pituitary. So I will correlate with the clinically to either any surgical history or.
So what is your diagnosis then?
Pituitary apoplexy.
Okay, I'll take over. Please remember, look carefully. If you see here, the pituitary gland is visible here. This lesion is suprasellar. A pituitary adenoma will always be sellar as well as suprasellar. So there is nothing in the sella. Sella is absolutely fine. The pituitary is normal. With that, this patient is 4 years old. As we have discussed in the previous case, in a 4-year-old, a pituitary adenoma like this cannot occur. Now, the point is that this is a suprasellar lesion which has got these fluid levels, some high signal on T1 weighted sequence. So this is a T1 weighted sequence, sorry, this is a T1 weighted sequence in which you can see this high signal here and a level there. And the teaching point or learning point is that in craniopharyngiomas, there can be fluid levels. There can be because of high proteinaceous matter, or there can be blood products also. So this is another case of craniopharyngioma, slightly atypical, but again, there was calcification on the CT scan. The key finding is that the pituitary itself is normal. So this is the differential diagnosis of suprasellar lesions. And this is the differential diagnosis of supratentorial tumors in childhood. And again, craniopharyngiomas will be there. This is once again, a case of hematoma of the hypothalamus. Similar case we have already done, so I'm going to skip it. But just to make a point that this is quite a large lesions. It can be up to 4 centimeter in length. It is projecting into the suprasellar cistern. And again, you can see that this is iso-intense to the gray matter on T1 and T2 weighted sequence. It does not enhance. This patient is a 2-year-old and presented with bleeding PV. Okay, candidate 4, please present this case.
Okay, so I'm presented with the sagittal and axial slices of MRI brain and T1 and T2 images and post-contrast, in which I can see there is expansion of the pituitary region and involving the anterior and posterior pituitary as well, and it's protruding in upward, involving the optic chiasm. However, I can't see there is involvement of the internal carotid arteries. And I can see there is some intensity, which gives us a heterogeneous appearance. So, on the basis of this finding, I can see there is the cavernous sinus is spared, as the internal carotid arteries appear normal to me. So my my probable diagnosis is a pituitary macroadenoma, and meningioma can also come in the differential. Okay.
Okay, now this case is a pituitary macroadenoma. It's a large macroadenoma. So what it is doing, if you stretch your imagination, the floor of the sella should have been here. It is expanding it, and actually the tumor is going into the sphenoid sinus, completely obliterating the sphenoid sinus. With that, there is compression of the optic chiasma. With that, there is a fluid level, and which is in keeping with pituitary apoplexy, which is bleeding within a tumor. As far as the cavernous sinus is concerned, this is what we call the cavernous portion of the internal carotid artery. If on the right side, it is invading the cavernous sinus. How? We will come back to this point. Coming back to the anatomy of the cavernous sinus, if you see this coronal, this is the internal carotid artery, the cavernous portion, and this is the cavernous portion of the internal carotid artery. Coming back to the nerves, this is the vagus nerve. The trigeminal nerve, fifth nerve. It goes into the Meckel's cave. Here is the Meckel's cave, where there is a ganglion there, the Gazerian ganglion. It divides into V1, V2, and V3. The V3 goes through the foramen ovale into the base of skull, through the base of skull into the neck. But V1 and V2, they go into the cavernous sinus. So on an axial, this is how it will look like. Now, if you see here, this is, just one second. I think what I will do is, I will show you this axial slice. I did show you this one previously also, but it's a good idea to revise it. Candidate 4, can you see this sequence on your screen? Candidate 4, are you with me?
Yes, sir.
Can you see this cis sequence on your
Yes.
screen? Okay, so I'm going to teach you here, so you don't have to worry about a viva here. So the point is that on a cis sequence, this tells you the anatomy very well. So this is the clivus. Now, as we go, concentrate here. This is the sphenoid sinus. Now, this is the sphenoid sinus. On this CSF and this CSF is Meckel's cave, and this is asked in the exam. And so Meckel's cave is in exam anatomy. Now, if you see here, this is the pons, and from the pons anteriorly, the fifth nerve is going here and the fifth nerve is going here. Just concentrate on the left side. You can see this fifth nerve goes into the Meckel's cave, and here you can imagine that it will divide into V3, V1, and V2. So just anterior to that, here will be the cavernous, the cavernous sinus. This is the pituitary fossa, which is visible here. So let's go back to where we were. Now, if you see this case, I'm going to ask you leading questions. This patient is a case of a 40-year-old presented with right-sided trigeminal neuralgia. If you see post-contrast sequences, there is actually a meningioma here, and there is a dural tail which is going posteriorly. There are some dural tails here also. Now, if you just candidate 4, concentrate on this sequence, which is a flare, and this is a T2 weighted sequence. What is happening to the Meckel's cave? What is the difference between the Meckel's cave?
So on the contrasted images, I can see there is an enhancement of the right-sided Meckel's Meckel's cave, and there is enhancement. So it shows that it's involving the Meckel's cave, and there is the fifth nerve passing through the Meckel's cave. So
Okay, so this is the Meckel's cave here, and this is replaced by this mass. And on a flare sequence also, it is replaced. So this is, why the patient had trigeminal neuralgia. Okay, thank you, candidate 4. Candidate 5, are you with us? So this is with contrast. That one was, this one was a flare sequence. This is with contrast, the same case. And here you can see this enhancement, which is replacing the Meckel's cave. This is the normal Meckel's cave. So candidate 5,
Yes, I'm here.
okay, now, so cavernous sinus lesions or parasellar lesions, this is another differential which you have to consider. And one point is that there are various, radiologically speaking, there are various kinds of parameters which can be seen to say if there is involvement of the cavernous sinus or not. Now, if you are a neuroradiologist, you divide the cavernous sinus into various compartments. I'm not going to teach you this, but anybody who's interested, if you Google it, this is an article from Radiology. It divides the cavernous sinus, and then it tells you how to say if the cavernous sinus is involved or not. In a FRCR2B world, cases will be more blatant, like this one, where even on an axial slice, you can say that the cavernous sinus is involved. But one of the objective criteria for FRCR2B is as follows. If you concentrate on this, this is the coronal sequence. This is the internal carotid artery on left side. This is the internal carotid artery on right side. And at just considered on the left side, 1 o'clock position, here 11 o'clock position, they say that there should not be more than 1.5 millimeter of enhancing focus at 1 o'clock on left side and 11 o'clock on right side. And you can see that there is a lot of this enhancing focus. Look at this case, and again, you can see that this is the internal carotid artery, and there is a lot of this enhancing focus. This is a case of meningioma, which is also slightly attenuating the internal carotid artery. So meningiomas can do that, but pituitary macroadenomas will not. So this is a case of pituitary adenoma. I'm going to skip it because we have already covered it, but you can see that there is cystic and solid component. It is going into the sphenoid sinus. It is compressing the optic chiasma, which is a very important exam finding, because you will urgently raise this issue with the neurosurgeons. If you see the internal carotid artery here and the internal carotid artery here, you don't see enhancement more than 1.5 or 1.5 on 11 o'clock or 1 o'clock. So it's doubtful that the cavernous sinus is involved. Okay, candidate 5. This is a post-contrast scan through the pituitary. The patient had hyperprolactinemia. What are your findings?
So I can see that the top first image, it's a flare. And so I've got flare.
Excuse me, this is not flare. All of them are post-contrast T1 coronals.
So I've got post-contrast T1 images, and on which I can see so the sala appears empty here.
No, it is not empty. You see, the point is that this thing is everything which is enhancing is the pituitary gland, which is enhancing.
So
hyperprolactinemia. What does it?
So hyperprolactinemia tells me that there's probably something involving the posterior pituitary, because that produces prolactin, the posterior. So the neurohypophysis and the adenohypophysis. So this would be a prolactin producing a prolactinoma, would be in a 27-year-old would be my most likely. So I could see that.
What is your finding? What is your finding? You have not pointed out to the finding.
So I can see there is so looking at the internal carotids, I can see there is a rim of contrast, but very bare, very minimum, not like 1.5 millimeter, just eyeballing it. So there's something in the pituitary which is displacing the carotids, and it's it's enhancing, and there's a low an iso-intense lesion in the left aspect. So it's just
okay, I'll take over because of the time factor. Now, please remember, now this is a classical case of pituitary microadenoma. This is the microadenoma. It is better seen here than here. It is a bit of partial volume. The concept is that on a post-contrast sequence, the pituitary gland enhances. There is no blood-brain barrier. And a microadenoma does not enhance as much as the pituitary. Microadenoma, this is what causes hyperprolactinemia. It is usually in the anterior pituitary, by the way. And the point point is that by definition, a microadenoma has to be less than 10 millimeter. Technique they can ask you in the exam. The technique is that a pituitary scan for microadenoma should be done in dynamic way, because usually you pick them up to 60 seconds. You know, you do a 30 second, 60 second, 90 second, 120 second delay with a auto injector, and you will pick it up as a low intensity focus, which is not enhancing as much as the pituitary. So this is a pituitary microadenoma. Okay, what is happening here?
So on the top sagittal looks like a post contrast. So I can see there is a within the sella, I can see there's this tissue which appears to be extending superiorly, and there's exerting a mass effect on the optic chiasm, as I can see on the coronals, and doesn't demonstrate yeah, so it's a tissue within the sella which is extending superiorly, just touching the chiasm but not extending beyond it. So doesn't appear like a macroadenoma. It appears smaller than 10 millimeters. So again, I'm thinking whether it is a microadenoma in a 32-year-old.
So this is cystic lesion. It does not enhance. It has got CSF intensity. What comes to your mind? It is sellar as well as suprasellar, as you have pointed out.
So it's a Rathke. It's by a differential way Rathke's cleft cyst.
Okay, fine. So Rathke's cleft cyst, you see what happens is that embryology has been asked in the exam. So I'm just quickly revising the embryology for you. Pituitary gland actually arises from two components. One is from the roof of the oral cavity, there is a Rathke's pouch, it goes superiorly. And from the diencephalon, which is the brain, there is another pouch which comes inferiorly. So this one produces the anterior pituitary, and this one the posterior pituitary. And in between, so this part, the anterior part is known as pars distalis, and posterior portion of the anterior pituitary is known as pars intermedia, and there is a cleft in between. And this cleft at times produces a cyst. This cyst can be intrasellar, it can be also intra as well as suprasellar, and rarely it can be only suprasellar. So this is known as Rathke's cleft cyst, and Rathke's cleft cyst can have various kinds of appearance. For example, this one, if you see on a T1 weighted sequence, if you see here, this is the pituitary gland, which is normal. Superior to that, there is this high signal. It might be because of proteinaceous matter. And this is a suprasellar Rathke's cleft cyst. So remember, intrasellar, intra and suprasellar, and only suprasellar, which is the rarest variety. Okay. Do anything. These are 5 cases which I am going to show you, and these are classical exam cases. Please remember pituitary gland and surrounding areas on classically in the exam, the examiner is going to show you an axial sequence, maybe on a CT scan, and if your mind will be going into brain, actually it's something happening in the pituitary region. So I'm going to show you these 5 cases quickly. Now on this case, you can see that this is the sphenoid sinus, and you can see something is there. And if you look now here, cavernous sinus must be involved. This is the pons. Anteriorly, there is a lesion. In the cavernous sinus, there is a lesion. And you can see one tongue goes superiorly. And now we are at the level of the midbrain, and something is there. On MR, it becomes very obvious. that this is a large pituitary adenoma. So you have to pick it up on a axial CT and then ask for this kind of imaging. Here you can see that there is a superior tongue here, and look at this internal carotid artery. And you can see that more than 1.5 millimeter tissue is there, means that there is cavernous sinus invasion. Now, another case, and here you can see something is there. You are not very sure if these are ectatic internal carotid arteries or something else. But if you look carefully, here is pons, and you can see something is in the suprasellar system. So on a sagittal CT, you can pick up another adenoma there. And this was the MR, which showed the same thing here. Another case in which you can see something asymmetrical. So it is causing erosion or expansion of the bone here. And it is on one side. It might be an aneurysm, for example. It might be an adenoma. And anatomy-wise, it is eroding the posterior clinoid process also here. And on bone window, this is what is happening. And on MR, again, you can see that this was a macroadenoma on one side, and it is causing a bit of expansion of the bone and is extending into the sphenoid sinus, but just on one side, not on the other side. This is a nice case to develop your eyes. This is a suprasellar arachnoid cyst. Please remember, arachnoid cyst can cause erosion of the bone. In this case, there is a arachnoid cyst sitting here, and it is, so this is the posterior clinoid process. This is the anterior clinoid. This is the anterior clinoid. This thing here is the optic foramen. So the cyst is here, and it is causing erosion of the posterior clinoid process. So look at this one. So this is anterior clinoid, posterior clinoid, and it is missing here because of the cyst. The cyst is just like CSF, very well visible here. And you know, in the suprasellar cistern, arachnoid cyst is one of the differential which is given in your book. Last case is this one, where you see this is pons, everything looks fine. Maybe the internal carotid artery is a bit erythematous. As we go superiorly, this is the midbrain. Something is sitting there, something extra. It becomes more evident. Something is there, so you have to pick it up. If you go down, there is nothing coming out of the sella. It is sitting superior to the sella, maybe at the floor of the third ventricle. And when you go for an MR, you can see that this is the sella. There is enhancing focus at the hypothalamus. You know, just like the first case which you saw today, which was in the tumor chapter, which was the hypothalamic hematoma. So this is a glioma of the hypothalamus, and it is showing enhancement. And this was a patient which was, I think, old age, 80-something or 90-something year old. Right. So these are the type of cases which you have to be careful, which will come in the exam. So from here, let's go back to where we were. Okay, this is your last case, candidate 5, and then candidate 6 should be ready. I'm giving you a limited limited sequences. So this is the infundibulum, and this infundibulum enhances, and this is a T2 weighted sequence. What will be your differential for this case? Candidate.
In a 9-year-old boy enhancing infundibulum, the first thing I'd think of would be an hypophysitis, secondary LCH hypophysitis.
LCH. LCH. Okay. Now.
Hypophysitis secondary to LCH, yeah.
So you are mixing up the two terms here, actually. You know, Langerhans cell histiocytosis will actually involve the infundibulum. Hypophysitis there is a bit of differential for that. IgG4 related, or it can be, lymphocytic, etc. So LCH is a very important exam case, because in LCH, if you go back here, this is from your book, the second part of Chapman, it tells you that the previous concept of Hand-Schuller-Christian disease and lateral-sieve disease has been abandoned. So LCH now is categorized based on disease extent. And we divide it in the peers group, we divide it into 3 groups. Unifocal unisystem disease, these are 70% of cases, and usually we are involving the bone, right? Now, there is second type, which is multifocal unisystem disease, 20% of the cases. So again, bone will be involved, but the lesions will have, these will be multifocal. The peak age here is 5 to 15 years, here is 1 to 5 years. And then this is the worst type, which is multi-system disease, 10% of the cases, peak age is less than 2 years. And in this, various parts of the body other than bones can be involved. And we are talking about CNS. So in CNS, there can be involvement of many things, but remember things like, skull involvement, things like meningeal involvement, etc., particularly the involvement of the infundibular. Then there is an adult type, which is unlikely to come in the exam. So if you see here, these cases can come in as a long case. So infundibular involvement with that stigmata of, MSK or bone, Langerhans LCH, vertebral plana, and aggressive looking lesions in other bones also. This is another example where there is thickening of the infundibulum. We are basically covering the differential diagnosis of infundibular thickening. Another case of LCH where you can see this thickening of the infundibulum. Please remember that infundibulum inferiorly up to 2 millimeter is taken as normal. Superiorly at the junction with hypothalamus, it is about 4 millimeter maximum. So this is the differential diagnosis of infundibular lesion. And this is the concept, infundibular lesions, where, this is LCH, Langerhans cell histiocytosis. But other types of non-neoplastic, where it can be, hypophysitis, which can be lymphocytic, which can be because of sarcoidosis. Sarcoidosis is very, very important. IgG4 related disease can also cause hypophysitis. So with that, LCH can also cause skull lesions. And this is a differential diagnosis in your book. Skull wall lucency without sclerotic edge. And LCH is given there. Langerhans cell histiocytosis. Okay, this is your last. Okay, candidate 6, are you with us? Thank you, candidate 5.
Thank you.
Candidate 6.
Hi.
Okay, this case is head and neck lymphoma. Clinically, they were worried that lymphoma has come back. Initially, there was a complete response to treatment. On this PET scan, are you worried, and what is happening?
Sure. This a coronal view of the PET CT. I'm looking specifically at any abnormal uptake region. I can see there's some asymmetry around the cervical region at the mandibular gland and also at the skull base.
So anatomy-wise, what is happening? Excuse me, because of time factor, I'll ask you a question. What do you think is happening where I'm, pointing out?
Yes. It seems like there's increased uptake on the bone, the skull base bone.
What will you like to do to evaluate it further?
So a CT head.
Okay. I have given you an MR, which I believe is better.
Sure. So this is a series of images of MR brain, which I will focus at the regional interest in the left.
Okay, just concentrate on this one and maybe this one.
Okay.
This is post-contrast.
Sure. So I can see there is iso-intensity 1 and hyper-intensity 2 lesion involving the muscle of the...
So this is post-contrast sequence, right? So there is a enhancement. Please continue.
Yes, involving what it seems to be a masseter muscle and also close to the mandible, the mandibular condyle, and involving the pterygoid muscle. And I'm looking specifically for any sign of bony destruction here, which I can't quite see that because on T1 I can see the cortical bone is preserved. So in summary, I have a muscular predominantly involved, a lesion predominantly involving the muscle, and also I'm trying to see whether is there any involvement of the cavernous sinus here.
Yeah. So is there?
As it's track out to the, because I'm using the left internal carotid artery as my reference point here, it seems that it's just lying lateral to it. And there's the normal vascular flow void still preserved here. So this is muscular lesions as enhancing and with intracranial extension. It is not in the midline, it's off the midline. There's no cortical bony destruction I can see.
What is this?
So that is our, so again, that is our suprasellar system. So there's Infundibular, and that on the last image there is the hypothalamus. So I'm looking at the last three images at the bottom. I can see the optic chiasm on the left.
Excuse me, because of time factor, let me ask you leading questions.
Sure.
Do you think that the cavernous sinus here is involved by this enhancing focus or not?
I think yes.
Okay, let me take over. Now, if you see here what has happened, and this is a very important case for head and neck world. I'll show you the next case and then you will see the anatomy. Basically, please remember that from the Meckel's cave, the V3, which is the third division of the trigeminal nerve, it goes through the foramen ovale and it goes into the masticator space. So this becomes a conduit for spread of tumors from the head and neck up into the cranial cavity. It can also go down, as in a schwannoma, for example, of the V3. So the anatomy is, if you see here, there is high uptake. There is a lymphoma here, which also goes through the skull base, and anatomy-wise, it can only go through the foramen ovale. So this enhancing tissue is recurrence of the tumor. On the next slice, it shows expansion and enhancement, and which is also seen here. So you can see that it is in continuity with this enhancing focus. And if you compare it with the right side, you can imagine that there must be some expansion of the foramen ovale. So apparently the tumor has gone here and maybe has gone into the infundibulum. So please remember the differential diagnosis of cavernous sinus lesions. One of the differential is a lymphoma. And similarly, lesions of the infundibulum, one of the differentials is a lymphoma. So that was the point of this case. I will show you another case. I will skip this one quickly, where there is a meningioma, and this meningioma also goes into the cavernous sinus. And you can see that the internal carotid artery is encased. So this meningioma looks like this beer, isn't it? So this is the type of case with that background. This is a very good exam case. What do you think is happening here? Look at the cavernous sinus on the left side. This is post-contrast. This is post-contrast. Over to you.
Sure. This is a series of MRI head of a 70-year-old patient with headache. So I'm looking specifically at the left cavernous sinus here. There is a mass lesion. I'm trying to work out whether is that involvement of the cavernous sinus. So this mass lesion is enhancing on post-contrast imaging. T1 iso intense, and it is slightly hyperintense on flare. So there is contact with the left internal carotid artery laterally. I'm reviewing the suprasellar system to just make sure there is no involvement within that. Right now, I'm trying to see where is this mass lesion is.
Here. What's happening here on this coronal post-contrast?
So this lesion is enhancing and also extending intracranially with displacement of the...
Anatomy-wise, what comes to your mind then? What will be your differential?
So meningioma would be one of them because there's meninges around here and dura. The other thing, other mass lesion here could be a schwannoma.
Okay. So this is the CT scan and this is the bone window. So what's happening?
So there is widening of the left foramen of ovale.
Right. So this is a schwannoma, and if you see here on a CT scan, there is something happening on the bone window. You can see this is the foramen ovale. It shows expansion, which is well-defined edges. This is classical for a schwannoma. And on contrast, it shows enhancement, and you can understand what is happening. From here to here is there's enhancement, which is actually the tumor. And this is a classical feature of a schwannoma. Jugular foramen schwannoma, which we will cover in head and neck, also will show similar behavior, where there is expansion, well-defined expansion of bone. Just like a schwannoma of, let's say, the rib cage or the spine. So there will be no bony destruction. So the idea here was to cover cavernous sinus or paracellular lesions. And I told you that these granulomatous or inflammatory conditions like sarcoidosis, TB, IgG4 related disease, etc. are also very important. But what we covered here was the schwannoma. And schwannoma is an exam case. What do you think is happening here?
So again, there's the lesions involving the left cavernous sinus.
What will you like to do next?
I will give contrast in this case. So on contrast itself, it seems that this is a vascular lesion because it has got the same enhancement as the ICA, internal carotid artery contact on the right side. So this is aneurysm.
Excellent. So this is another case, just to tell you that there can be aneurysms of the internal carotid artery. How will you describe this and what is your differential?
So this is a skull, lateral skull X-ray, which demonstrates a focal lytic lesion. I'm looking specifically at the edge with some fading opacity. So that's in keeping with the bevel age. So my impression is that this is a LCH.
Right, but what is this?
But there is a central focal hyperdense focus, so it could represent a button sequestrum.
Okay, so your diagnosis is absolutely correct. But if I ask you the differential diagnosis of a button sequestrum, what will be your differential?
Osteomyelitis can give that, but not typically. It just escaped my mind just now.
Chronic osteomyelitis.
Yeah.
Osteomyelitis can give you, right?
Yeah.
Okay, now the point is that the learning points here, which are very well described by candidate 6, are beveled edges. Beveled edges mean that there is bony destruction of a different magnitude of the outer table and the inner table. If you see the edge, it will give you this faded type of an appearance, which you can see here, which you can see here. So this is 1 and this is 2nd, and this will give you an appearance as you are seeing it and on. Button sequestrum is also a pathognomic type of finding, not exactly pathognomic, but one of the findings which we can see with LCH. But chronic osteomyelitis can also show us the same thing. This is the differential diagnosis of skull wall lucency without sclerotic edge, and Langerhans cell histiocytosis is given there. This is skull wall lucency. Okay, there is this is a continuity of the same thing. Now, this is another case which I just want to show you actually what happens. If you look on the CT scan, you can see this button sequestrum very well. And actually what happens that in Langerhans cell histiocytosis, there is involvement of the meninges. And from there, the lesion can penetrate the skull. And you can see this enhancement, etc. And it can cause this. The concept about a button sequestrum is that they say that this is actually avascular necrosis of the central portion of the bone, which appears as a button sequestrum. Another case here, this was the case which we saw initially. So the beveled edge, just to highlight that, this is how a beveled edge looks like, and this is how it looks like, and this is another example, which is from STAT-DX. And another example where you can see beveled edges as well as button sequestrum. Look at this case. At times, multifocal Langerhans cell histiocytosis can cause this. And if you start seeing them carefully, For example, just see this one and you can see that there is a beveled edge here and another beveled edge here and here. So this finding is important for your exam. Okay, candidate 6, this is your last case. This case has got a lytic lesion with a sclerotic edge. What is your differential for this?
Metastasis.
Sclerotic edge.
Sclerotic edge.
Sclerosis means something is sitting there for a while, isn't it?
Yeah.
There can be metastasis, but
Epidermoid cyst.
Epidermoid cyst. Okay. So this is the CT scan of this patient, in which you can see this. Actually, somebody had done a bone scan also. These days, nobody should ask for a bone scan like this. Initially, you can do an MR actually. And epidermoid cyst, this is skull wall lucency with sclerotic edge. And epidermoid is one of them. And if you do a diffusion weighted scan, please remember the concept that epidermoid cyst is the same thing as a cholesteatoma in the temporal bone. When it occurs in the intracranial cavity, when it occurs in the skull, other than temporal bone, we call it an epidermoid cyst. In the temporal bone, we call it a cholesteatoma. By definition, epidermoid cyst shows restricted diffusion. And we can use a DWI sequence to sort of characterize this. And this is the lesion, which on a CT scan, it is, a difficult type of findings. But on diffusion, we are quite confident of what is happening. Candidate 7, please.
Hi.
Okay, what is this?
So this is a lesion in the skull, which has got a irregular edge and central areas of increased density. Depending on the patient's age, this could be possibly a metastasis or possibly epidermoid cyst as well.
It has got a pathognomic type of an appearance. If you see here, this is what we call the honeycomb appearance. It has got a classical, look at these trabeculae, metastasis, etc., will not give you this kind of an appearance. And the point is that similar to this, look at this. Now, this is what we call hemangioma.
Okay.
Another case is this one. And again, you can see this honeycomb appearance, which is visible here, and a bit of sclerosis. And honeycomb appearance is, a classical case of hemangiomas. Please remember that many of the cases are not classical. But if you see a honeycomb appearance, call it hemangioma. Your book tells you that hemangiomas can be with sclerotic edge, and it tells you it is usually without sclerotic edge. But I've just shown you 2 hemangiomas which are with sclerotic edge. So if you can add this in your differential diagnosis in your book, if you see there is this sclerosis. So the type of hemangioma which I want you to remember for the exam is this honeycomb appearance. And all hemangiomas might not be like this. 8-month-old baby, swelling scale, what is happening?
So there is a fairly geographic area of lucency in this patient's skull towards the vertex. This appears to be a leptomeningeal cyst, probably in keeping with a growing fracture.
Excellent. So a leptomeningeal cyst, what happens is that when there is a fracture, there is a dural tear, and the arachnoid can actually go and in between the two fractured segments, and usually because of CSF pulsations, it might go out of the dura, and then it grows because of CSF pulsation. And if you clinically speaking, there will be a boggy type of swelling there. On imaging, this is what you can get. But usually, leptomeningeal cyst will be asked on a plain film, and you can see there is no marginal sclerosis. And this is why skull wall lucency without sclerotic edge, which is this one, is given in your book. Is this stroke or not?
So this is a single axial slice of a 50-year-old patient's CT head. It's an A&E study. There are several lesions which appear to be have a ring appearance configuration to it, and surrounding low attenuation, which is likely edema. So I don't think this is a stroke. This is metastasis or possibly abscesses. So I'd like to give some contrast if the patient's still on the table on MRI. So
now the point is that you did well. You have picked up that this is not a stroke. You asked for contrast, which is fine, and this comes in the exam quite a few times. Now I have given you post-contrast, and these are multiple ring-enhancing lesions. So the idea here is to cover the differential diagnosis of multiple ring-enhancing lesions for your exam.
Okay, so these are 4 axial slices and a coronal size of an MRI of this patient.
No, you see, we are short of time. I just answer the question which I am asking. We know that these are multiple ring-enhancing lesions. You just tell me the differential diagnosis of multiple ring-enhancing lesions.
So it can be metastasis, abscesses, can be multiple cavernomas, neurocystic.
Cavernomas will enhance like this. Question.
I would say no then. Yeah. But given the vasogenic edema around it, I think this is more likely to be either metastasis or abscess.
Okay. So this is the differential diagnosis of multiple ring-enhancing lesions, and it has been asked in the exam. So it's very simple, by the way, but at times you don't remember it. So it's a good idea to cover it. Now, tumor or abscess is a classical scenario which is asked in the exam. And in the exam, you will tackle it with a diffusion-weighted scan. But having said that, on other sequences, they are though not very good, but some of the parameters, let's revise them. That if you see that the ring enhancement is smooth, then it is more likely to be an infection. If it is nodular and irregular, it is more likely to be a tumor. But having said that, we are not very good, and that is why diffusion-weighted scan is the pink sequence there. You can see this case I have shown you previously. You can see that there is enhancement here. There is enhancement of the ependymal lining. And on DWI sequence, you can see this restricted diffusion. Tells you that in the central part, there is pus. And this is what they ask in the exam. Key point to remember is that the central part, which is the liquefied component, shows restricted diffusion on DWI sequence, while a tumor might enhance in the solid part, might show restricted diffusion in the solid component. Okay. Just to make a point that multifocal GBMs, as in this case, can also show restricted diffusion. So, over to you, what's happening?
Okay, so these are multiple axial slices of a CT scan non-contrast study. So in the lower row, and on the second and third images on the top row as well, there appear to be lower attenuation within the splenium of the corpus callosum. And I think that extends to the lower slices as well. There's a bit of local mass effect and possibly some vasogenic edema. So I'm concerned that this may be a mass lesion which is crossing the corpus callosum posteriorly. Differentials include a GBM, possibly, I think GBM refers differential.
So your differential is GBM and?
Lymphoma as well.
Okay, very good. So this is the MR of the same patient.
Okay, in these there are multiple fluid sensitive and fat suppressed sequences. The lesion is now well seen and enhances with the contrast imaging, and there is associated vasogenic edema as well. Looking at the sagittal slices, I don't see any drop metastasis going down to the spine or any involvement of the CSF spaces. There's no hydrocephalus as such. I think looking for the diffusion weighted scans. So on the diffusion weighted scans, there is resistant diffusion noted in some parts of the lesion.
So what is your conclusion?
So it could be either or, but I think given there is some irregular enhancement, this is more likely to be a GBM.
Irregular enhancement is not a differentiating point which can happen in both of them. You see, classically lymphomas, of course your differential is fine, so I'm not challenging that. But out of these two, lymphoma will be up there because classically, there is periventricular subependymal type of spread of the lymphoma, and it will show restricted diffusion. So out of these two, lymphoma, you will keep it up there. And this was a case of lymphoma. Okay. This is another case, just to make the point. This case was AIDS patient, but I'm just showing you the DWI sequence, which shows this. You can again see what is the unique spread, subependymal periventricular spread, which shows restricted diffusion. So the idea here is to cover the differential diagnosis of corpus callosum lesions. And neoplasia, as in butterfly glioma and lymphoma, are up there. But diffuse axonal injury is very important. I'm not going to show you a diffuse axonal, which we will cover in trauma. But cumulative MS, always keep it in your mind. It has come in the exam. Cumulative MS is a type of MS which appears like a tumor. Actually, it's a big lesion, and you will confuse it with a tumor. So this is a case of cumulative MS. Actually, initially, you just pick it up and you say that this is corpus callosum, and there is a bit of restricted diffusion, etc. And if you say a lymphoma, considering the age group is young, you are absolutely fine. But this was cumulative MS. So keep that in mind. Okay. This is a GBM where you can see this necrosis, etc. You can see it is crossing the genu of the corpus callosum and going a butterfly glioma, which is crossing over to the other side. A lot of necrosis. Necrosis is taken as a sign of high-grade tumor. Literally a butterfly type of a CT scan, on a CT scan lesion, butterfly glioma. This is a very good exam case. What do you think is happening? And these are the post-contrast. If you can concentrate here and tell me your diagnosis.
Yeah, so this is a central lesion epicentered on the parathalamus region and at the skull base with enhancement. It's fairly well circumscribed and appears to be extra-axial. So I think this is likely to be a meningioma.
Excellent. So this kind of a case can come in the exam, or or has come in the exam, what happens is when you are seeing the axial sequence, a meningioma, which is what we call olfactory groove meningioma, it goes superiorly in between the two frontal lobes, and it causes a lot of edema. And in exuberance, candidates pick that up and they say that this is a GBM, a butterfly. Actually, the key thing is that it is a meningioma. It is adherent to the skull base. There is a bit of a dural tear also here. So this has come in the exam, and many a times candidates have confused this. What is the spot diagnosis here? I have shown you this case, but on an MR.
So I think there's a significantly low attenuation lesion in the left temporal region. I think this is possibly fat. So I think it's a dermoid cyst, possibly.
Which has done what?
Ruptured.
Ruptured. So this is a ruptured dermoid, and the key here is that within the CSF, you can see this low density. You can do the Hounsfield if you want, and this is blacker than the CSF. So these are droplets which have gone into the CSF. And please remember that they have shown cases of droplets in the CSF in the brain, and actually the dermoid was sitting in the spine. So you have to ask, if you don't pick up the dermoid and you pick up fat inside, then go for the spinal imaging. This is the same case which I had showed you last time, but this is on MR, and you can see that how the fat goes into the CSF, and then it shows fat saturation. So this is the same case on MR. So here we go into a different differential diagnosis, and this is intraventricular tumors. So over to you.
Okay, so these axials, 4 axial slices at a sagittal. In the second image, it's T2 weighted, high signal intensity, lesion seen epicentered in the left ventricular trigone. There are areas of low signal within this lesion itself, and there's possibly some mild hydrocephalus on that side compared to the contralateral aspect. And looking at the sagittal images, I don't see any other lesions at our levels. Differentials for this appearance include...
There is no enhancement, right?
Sorry. Okay, sorry. No, yeah, the sagittal image has no enhancement of this lesion. So if it was a choroid plexus papilloma, it would probably enhance, so that's not likely the case. So I think this could be a cyst within the foramen of Monro. Could be other foramen Monro lesions as well.
If you go back to your anatomy, this is the body of the ventricle,
Yeah.
and the lesion is there. It is not a cyst. It is high signal on T2, but it is not exactly a cyst. It does not show any enhancement. So now if you go back to your differential diagnosis, intraventricular mass in adults, and intraventricular, as you have pointed out, that it does not show enhancement. So you see, it has to be a low-grade tumor. Like a low-grade means, as in malignancy-wise. So, central neurocytoma, oligodendroglioma, both of them might not enhance. And this is another example. Intraventricular oligodendroglioma, which shows calcification, and though I have not shown you here with contrast, but this also did not show any enhancement. So these two tumors, central neurocytoma and oligodendroglioma, should be in the differential of the case which I showed you.
Okay.
This is an intraventricular tumor, though just on this sequence you become very confused. So I'm giving you a hint, it's an intraventricular tumor. What is it?
So it's calcified.
Yeah.
So it could be it's a choroid plexus lesion, which is fairly long-standing. Could be a
So this is it.
So there's enhancement. So I think it's a vascular lesion. So my differentials include choreplexus, tumors.
Look at the calcification. That is why I showed you the calcification.
Intraventricular meningiomas.
Excellent. So this is an intraventricular meningioma here. So that is why I have shown you this case, that this is an intraventricular meningioma. What is this? This is your last case, and then candidate 8 should be ready.
So there's a high signal lesion at the, not the pineal.
Anatomy.
So it's in the third ventricle. So it's a colloid cyst, I think.
Colloid cyst, and colloid cyst is sitting at the foramen of Monro.
Yeah.
Right? This is the foramen of Monro, frontal horn, and this is colloid cyst, which can be high signal on T1 weighted sequence. This is another one which you can see here, and low signal on T2 weighted sequence. Candidate 8, please. Thank you, candidate 7.
Thank you.
Okay, candidate 8, thank you for waiting. Are you with me?
Yes.
Okay, we have got 2 differentials to go. One is pineal lesions. Another one is CP angle. The third and the last thing which is left here is meningeal enhancement. So, or meningeal lesions. Meningeal lesions we had already covered in the previous section. So for today, 2 differentials are left. One is pineal, and second one is CP angle. So I think, though we are running out of time, but I think we will just crack on and in 10-15 minutes finish them. So over to you. What is this?
So selected MR sequences, a 32-year-old female patient who we are told has a headache. There is a lesion at the posterior aspect of the third ventricle, consistent in location with the pineal gland. On T1 pre and post contrast sequences, it's ISO intense and doesn't show any enhancement.
What is your conclusion? What is your conclusion?
And it's flare hyper intense. I think this is consistent with a cyst. It's very well demarcated and not enhancing.
Okay. So the point is that pineal region masses, if we see what are the take-home points for the exam, pineal cyst is a very, very common incidental finding. Usually we don't consider it symptomatic. But the tumors can be, the tumors, the most common tumors of the pineal are, there is a lesion, by the way, which is pineocytoma. Nobody is going to show you a pineocytoma in the exam because it's very difficult to differentiate it with a pineal cyst. So we don't want to go into that territory. But the lesions which are important for the exam, the top lesion is germinoma. Germinoma is the most common. And in germinomas, think like seminoma of the testes. So they can be some, various types. The viva question there is that whenever you see a pineal lesion, you consider germinoma. It will be a solid lesion. You consider germinoma in the differential diagnosis. You have to ask for, assays, evaluation within the CSF as well as blood. You have to ask for placental alkaline phosphatase. You can also ask for alpha-fetoprotein and beta-HCG. These tumors, they actually secrete them. And the key thing is it's a viva question that you have to ask in the CSF as well as in the blood. Second concept is that out of malignant lesions other than germinoma, parenchymal lesion like pineoblastoma, you have to remember. Both of these lesions, they show drop metastasis. Remember this. Key differentiating point is age of patient. Germinoma is young adult, classically, let's say 20, 18-year-old, 20-year-old. Pineoblastoma is going to be less than 5 years of age. So this is the key feature between the two. Another point to remember is calcification. Please remember the concept of calcification of pineal gland. Normally, a pineal gland will show calcification. So the point is that if the lesion is arising from the pineal gland, the calcification will be pushed to the periphery. So peripheral calcification means that the lesion is arising from the pineal. On the other hand, if the tumor is not of pineal origin, as in germinoma, the calcification might be central. These are given in the books, though in each and every case, it is difficult to convince yourself about these. So these are the type of cases in the pineal world and the viva questions which can come. So this was a pineal cyst. On a CT scan, look for bracket sign. You see, this is known as bracket sign. Basically, there is expansion of the pineal, and that is why the calcification has gone to the periphery. And this sign is known as bracket sign. Okay. Where is the lesion? Which sequence? So, top row or
So
bottom
I
row?
think the one in which it's most prominent is the bottom left. And probably the
Can I stop you there? Can I stop you? Well done. So the point is that again in the exam, examiner will show you a pineal lesion on an axial slice. Nobody's going to show you a sagittal MR initially. So the key anatomy finding is that look for this slit of the third ventricle, and there will be thalamus here, thalamus here. Posterior to that is the pineal. And if you see something there, then you call it a pineal lesion. So we have picked up a pineal tumor and we have picked up a bit of hydrocephalus. What would you like to do next, please?
I think it would be interesting to know if it enhances.
Okay, so I have given you MR, and if you can concentrate here, what is happening?
So that's a sagittal T1 post-contrast sequence, and the lesion demonstrates heterogeneous enhancement, and it's causing hydrocephalus due to blockage at the origin of the aqueduct, at the exit of the third ventricle.
Okay, very good. So what's your differential here?
So I think this is a neoplastic lesion. There weren't any calcifications on the CT scan. I'd like to know the age of the patient, but this could be a...
It is not exactly a baby, isn't it? Even on this. So this is an adult.
Yeah, it looks like an adult. So maybe a pineal germinoma.
Excellent. So this was a germinoma. And what is happening here? 20-year-old. Just concentrate on this post-contrast.
So there's a homogeneously enhancing mass centered on the pineal. On these sequences, I can't see any evidence of hydrocephalus, although I'd need to look more superiorly.
What is happening?
So there's some enhancing material in the region of the falx, or possibly the straight sinus.
So what do you call this?
This could be leptomeningeal metastases.
Dural, right? Leptomeningeal. Yeah. So the point is that the same part of anatomy, this is the third ventricle and there is a mass here. What would you like to do next?
I'd like to know if there's any calcifications, if this patient's had a previous CT scan.
No calcification. Anything else?
And I test the patient for serum or CSF biomarkers of hormonally active tumors.
Any imaging you want to do or see?
So there's this lesion's already demonstrating metastatic potential, so I'd image the rest of the neural axis looking for drop metastases.
So this is the answer that I will evaluate whole of the neural axis. Please remember germinomas, and in a young age group, Pineal, they will show this drop metastasis. And this is pineal tumor, germinoma or pineoblastoma. It is in that differential. This is a 16-year-old with a huge germ cell tumor with raised placental alkaline phosphatase, just to make the same point. And there is a lot of hydrocephalus. Actually the floor of the third ventricle has gone down and compressed. This is a pineoblastoma. Look at the age, 18 months. And you can see this tumor here, and the calcification is a bit peripheral. Age is the main parameter. Age changes the game. Otherwise, you remember the case which I just showed a while ago of germinoma. It was similar to this one, isn't it? But the age is the main thing. So under 5, pineoblastoma, malignant looking, and young adults, germinoma. And both can cause, CSF drop metastasis. What is this?
So it's a midline fat density area. So just looking at that, it could be a lipoma of the corpus callosum.
Excellent. So the idea here is to develop your eyes on an axial slice. How will a lipoma of the corpus callosum look like? If you see here, this is the splenium. Part of it goes around it. So this is low density. Then as we are going through it, the slice is going through it. It is here. And on a MR, of course, this is how it looks like. By the way, this is not exactly the same patient, but just to highlight how it looks like. Lipoma of the corpus callosum can be an incidental finding. It can also come in the exam with agenesis of the corpus callosum, which I'll show you later on in the congenital wall. It's an important exam case. Okay, last differential diagnosis of the day, which is the CT angle. So can you describe and what is the differential diagnosis for you?
Okay, so selected axial MR sequences, 50-year-old female patient. There's a large mass lesion in the left cerebellopontine angle, which looks to be intradural. It's quite heterogeneous, but roughly iso intense in the periphery on T1 with avid enhancement and some centrally non-enhancing higher T2 areas potentially suggestive of necrosis. So I think that this could be this is likely to represent a malignancy. Just trying to establish which one. Incidentally, there's
excuse me, in the beginning, when we started this exercise of brain tumors, I told you that the differential diagnosis will change, and this is why the bookish differential diagnosis is very important. This is a CP angle lesion, and if you go to the differential diagnosis, cerebellopontine angle mass, look at this. Vestibular schwannoma, meningioma, a vast majority of them are these two and nothing else. And then epidermoid, ependymoma, arachnoid cyst, etc. Very, very rare will be dural metastasis. Now, this is a large lesion which is sitting there. Now, let me take over. First of all, how will you tackle this? Once you know this differential diagnosis, first of all, this is a CP angle mass. It is extra axial. there is a CSF cleft sign. It is sitting outside the parenchyma. Now it shows enhancement. The central portion does not enhance. I don't know if there is calcification here, but might be there. Now, pertinent negative will be, is it extending into the IAM or not? Because your differential is acoustic schwannoma, and this one is not. And if it was so large, it should have gone in as in a schwannoma by now. Is there a dural tail or not? Is there calcification? Are used to differentiate an acoustic schwannoma from a meningioma. So I repeat, these are the top two masses of the CP angle. And is it going inside the IAM? Most likely than schwannoma, though meningiomas at times can also go in. Is there a dural tail sign, which is not an absolutely pathognomic sign of is there bony hyperostosis, meningioma? So this is how you differentiate between the two. What is happening here?
So at the top, we've got a highly T2 weighted CISS sequence, which shows a lesion in the left CP angle, which is entering and expanding the left internal acoustic meatus. This lesion is enhancing on post-contrast sequences, has appearances consistent with an acoustic schwannoma.
Okay, so acoustic schwannomas, they will usually show you a cis sequence for this, if it is a small lesion. Otherwise, they might show you some other sequences. If it is a small lesion, for example, if you see this, barely you can pick up something. And then when you give contrast, it is enhancing. Similar lesions I have shown you in the past also. Now, what is this?
So there's a cystic left cerebellopontine angle lesion, which is causing some mass effect. In terms of signal, it's high intensity on T2 and completely nulling on the flare sequences. So I think this is likely to represent an arachnosis.
Excellent. So please remember, epidermoid versus arachnoid is an exam case. Epidermoid will show some sort of signal on a flare sequence, because on a CT scan, both will appear CSF density. They will show you a CT scan, and then the viva will start and you will ask for an MR. So epidermoid will show some signal on flare, not complete signal void, and diffusion will be absolutely pathognomic. So this is an epidermoid where it is CSF on T2. There is a bit of signal on flare, no enhancement, but on DWI it shows restricted diffusion. Okay, now we have ended the differential diagnosis. The last thing which I wanted to show you today is dural and leptomeningeal enhancement because of malignancies. These have been done last time. So I am just going to quickly show you 1 or 2 or 3 new cases. And in the end, I will show you the last case of the day will be what we call pseudo-tumor cerebri or spontaneous, idiopathic intracranial hypertension is the last case which I am going to show you. So 3 or 4 cases are left, and rest are all cases which you have seen last time. But please remember that when you are covering tumors, leptomeningeal carcinomatosis or dural carcinomatosis, skull involvement is very important for the exam. So I'm repeating it just for that purpose. This case is 76-year-old, A&E, clinically stroke. Do you pick up anything? There was no stroke, by the way.
I can't say anything is jumping out. On the bottom left image, there looks to be something sort of high density material in the extraaxial space on the sort of right convexity.
So what can it be? Is it a subdural hematoma?
It could be an acute subdural, especially if there's any history of fall or injury.
I have given you an MR for this. What do you think is happening?
Okay, so just concentrating on that abnormality that we saw on the CT.
Let's concentrate on this pre-contrast T1 and post-contrast T1.
So firstly, the area that is in the extraaxial space is enhancing, which obviously no subdural collection would do within the fluid itself. So that it's got a very nodular appearance. And then I also note that there's loss of the normal fatty marrow in the diploic space in the overlying calvarium.
Very good.
So I think so. This is a dural metastasis with bone invasion.
Excellent. So just a recap of the anatomy which we covered last time, that this is the diploic space, this is the outer table, this is the inner table, this is the dura, which has got, the periosteal layer, and this is the deeper layer. The dural venous sinus is in between the two. This red thing is the arachnoid, this is the subarachnoid space, and this is the pia. We are talking about processes which involve the dura, processes which involves the leptomeninges. Leptomeninges means arachnoid and pia. Pachymeninges means dura and arachnoid. And these are very important. So there can be what we call carcinomatosis. There can be other things like TB and fungal infections, etc. Now, the key thing here is, in this particular case, look at the marrow. Look at now the diploic space on the T1 weighted sequence, the marrow is high signal. You can see that is that normal marrow is gone. This thing then enhances, you can see it is going inside. So this is dural metastasis. And so this was meningeal enhancement on CT and MR, and which for the examinations, it can also come as a long case. Something in the chest and something upstairs in the brain can be given to you. This is dural metastasis in the case of rhabdomyosarcoma. I have shown you previously, but just to make a point, from here it is passing through the skull and actually going into the scalp. This is leptomeningeal carcinomatosis. The key thing is that on an MR, there is high signal within the sulci on the flare sequence. When you see this, it can be a leptomeningeal process. It can also be subarachnoid hemorrhage. You give contrast. When you give contrast, it enhances. If it enhances, means that it is a leptomeningeal process, and the differential is as we have considered previously. But this one was esophageal carcinoma. Look at another case of breast cancer, where there is leptomeningeal enhancement and maybe dural enhancement also. And all of this is leptomeningeal carcinomatosis. Another case in which there is dural enhancement and maybe leptomeningeal also, because it is going into the sulci. So this is another case of metastasis. And look at this case, classical exam film of sarcoidosis. What is happening? Infundibulum is thickened. With that, there is dural thickening. With that, there is parenchymal lesion. So the greatest mimicker in neuroradiology, which is sarcoidosis, What it can cause is infundibular thickening, it can cause dural enhancement, it can cause leptomeningeal enhancement. And it can also cause intraparenchymal abnormalities or pseudotumors. What happens is that from the perivascular spaces, which pass into the brain, the granuloma passes into the parenchyma, giving you the appearance of intraparenchymal lesion. This is a case from our collection in which this was a young female, and if you see, there is a lot of enhancement which is in continuity with the dura. And look at the edema, etc. When we did this, we were worried about metastasis or some primary lesion. And later on, we realized that the patient had actually sarcoidosis. And the patient had a CT and abdominal, chest and abdominal lymphadenopathy, which I'm not showing you here. So this kind of a case can come in the exam. Second last case is a repetition, which is now the final differentials, final two conditions for your exam, and then we will stop. This is spontaneous intracranial hypotension. Please remember, spontaneous intracranial hypotension has come in the exam quite a few times. And basically what happens is that for some unknown reason, at times there is a known reason like trauma or surgery or some intervention, the patient loses CSF. When the patient loses CSF, there will be, according to what we call the Monro-Kelly hypothesis, there has to be an equilibrium between the volume of intracranial blood, CSF, and brain tissue. So when the patient uses CSF, then intracranial blood, which is within the veins, that the veins become engorged. And when they become engorged, radiologically speaking, there is dural thickening, just like this case, which is visible on this flare sequence. And you can see this inner table, this is outer table. And when you give contrast, it shows enhancement. So this case we have considered previously, last time. And the classical exam case is this one, where there is sagging of the midbrain, and with this there is diffuse dural enhancement. But this was, please remember, hypotension. So the CSF is low. There is another entity which we call idiopathic intracranial hypertension, as in increased blood pressure, that kind of hyper. That case, according to the feedbacks which I have, has not come in the exam. I might be wrong. But what I feel is that the bar in FRCR exam is going up and up. So if somebody can give you spontaneous intracranial hypotension, I believe can also give you idiopathic intracranial hypertension. And I'm going to show you a case. And this is the last case for candidate 8. Can you describe the findings? I have given you the diagnosis. Over to you.
So knowing that that the patient has idiopathic intracranial hypertension, there's a generalized increase in the subarachnoid space, more than you would expect for a 31-year-old patient, especially obvious at the vertex aspect of the brain. Looking on the axial G2, we can see that both optic nerves are tortuous and kinked, with some high signal around their sheath of, again, CSF signal intensity. And then if we look on the sagittal sequence, there's an appearance of an empty cellar, presumably because of pituitary compression due to the intracranial hypertension.
And what's happening to the venogram?
So the venogram is demonstrating reduced signal in the region of the left transverse sinus. which might indicate venous compression.
Okay, well done. Okay, I will take over. You can mute yourself. So this is the last case. Let me describe you the findings. So what happens in spontaneous, idiopathic intracranial hypertension? There is CSF is more than what is should be there. So there is prominence of CSF spaces. This entity was also known as pseudotumor cerebri previously. Now we don't use that word. So what happens is, radiologically speaking, you have to pick up. There are many findings, but the main exam findings are partial empty cella. Partial empty cella can also be a sort of an incidental finding, but you have to pick up other findings with it. Partial empty cella. Meckel's cave will be prominent. So this is Meckel cave, which will be prominent. Key thing is that you can see the optic nerves. The CSF around the optic nerves will be prominent. Look here. The CSF around it is prominent. You can also see the CSF around the optic nerves is prominent. There can be indentation at the sclera, at the optic nerve end. The optic nerves will be tortuous. So these are the key findings. With that, go for MRV. On MRV, what can happen is that there can be attenuation of the venous sinuses. It's not thrombosis, it's attenuation. So at times they do interventional radiology, stenting, etc. of the sinuses to treat this condition, which can be quite significant.